Good morning, everyone. Thank you for joining us today. So a few housekeeping notes before we get going with the actual meeting. First, I'd like to go over today's learning objectives. After completion of this activity, participants will be able to explain how real-world data can augment clinical trial data, describe how real-world disease treatment patterns impact outcomes in patients with retinal vascular disease, identify gaps in care through real-world data studies, and use real-world data studies to inform practice decisions. This activity is supported by an independent medical education grant from Regeneron and Genentech. I want to thank my co-directors, Durga Borkar, Rishi Singh, for helping us set up this wonderful conference, as well as all of our wonderful faculty who you'll be hearing from today. And a big thank you to our sponsors, Genentech, Regeneron, and Apellis, and Iveric Bio, who without them, this conference wouldn't be possible. As far as questions during the talks, there is a Q&A button down at the bottom of your screen. Please feel free to put questions in there. At the end of each session will be a panelist discussion where we'll go over the questions that are brought up during each individual talk. So let's get started. So I'll be the moderator for the first section, Introduction to Real-World Data and Data Sets. And our first talk will be by Jason Shu, What to Know About Using Electronic Health Record Data.
Thank you, Durga, Rishi, and Brian, for allowing me to be a part of this summit. I'm going to kick things off by providing a broad overview of the pitfalls and promises of using EHR data for clinical research. The first thing everyone should recognize is that real-world data is, to put it nicely, messy. The term GIGO, or garbage in, garbage out, certainly applies here. When we conduct clinical research using EHR data, the quality of the study as well as the results are highly dependent not only on the presence of the data that we're looking for, but also the accuracy when it is input into the system. The problem is that the data in EHRs is generally non-uniform and almost always not standardized. Keep in mind that the data we are trying to use for research is primarily intended for patient care and even for the purposes of billing. Thinking about some of the problems plaguing EHR data, it's easy to start off by realizing that there is a lot of missing data. It's surprising how often basic stuff such as visual acuity, IOP, and specific exam findings are missing. On top of that, medication lists may be incomplete, the medical or surgical history may also have holes, and labs are frequently not recorded, perhaps because sometimes we're relying on self-reporting and patients just don't know or remember. A big issue for many of the studies we do is the diagnostic testing, such as OCT, is not incorporated into the EHR in a meaningful way. Another issue is searching for the data you want. If it's not a standard diagnosis or procedure code, it can be tricky to find all the subjects. For example, if we're doing a study looking at sclerofixated IOLs, we could do a free text search to try to find all the patients. However, different clinicians document the findings in various ways, so then you have to do your best to try to figure out all the different possible iterations. When critically reading real-world studies, I think one of the main things to always remember is that the data is not standardized. Duration of events may be inaccurate or missing. For example, the duration of a Makoff RD is often solely dependent on patient recall as to when they lost their central vision. However, depending on how the question is asked and how attuned patients are to their symptoms, the recorded answer may be quite far off from reality. Visual acuities are also typically measured on Snellen charts in most practices. Since there is no standardization on room lighting, brightness of the chart, technician skill and patience, and sometimes even distance of the patient from the chart, this recorded data may vary from practice to practice and even location to location within a given practice. The next issue is our grading systems. Say we want to do a study dealing with the severity of cataracts or uveitis. Our 1 to 4 plus grading scale is highly subjective as most don't strictly follow any standardized systems. Accuracy of the data is another concern. There is some subjectivity in clinician grading of certain diagnoses such as mild, moderate, or severe NPDR or early, intermediate, and advanced AMD, unlike in clinical trials which use a reading center to more objectively grade disease severity based on standardized images. Speaking of accuracy, so-called quantitative measurements may even be problematic. For example, when OCT data such as retinal thickness is input into the EHR, it's also hard to know whether it is being measured accurately at the foveal center, whether it is a single point thickness measurement or the average 1 millimeter central subfield thickness, etc. Finally, we have to consider that in the real world, there's variability in sampling frequency. Clinic visits do not follow some standardized schedule. So if you're looking at a study with 1-year outcomes, the data may actually encompass a wider range of visits, perhaps anywhere from 9 to 15 months. The last negatives I wanted to discuss are some of the pitfalls and a few examples when we use real-world data for clinical studies. First is, how do we deal with missing information? One option is we could exclude patients that don't have all the data we need. For example, let's say we're doing a study on the correlation of A1C with treatment response to anti-VEGF injections. It makes sense that we would then exclude all patients who don't have an A1C in their chart. However, we may be excluding the least compliant patients with the worst control who just don't know that number and therefore end up with patients who are generally more compliant and are living better lifestyles, which may skew the findings. Additionally, if we're only including patients who have all the fields we want, it's possible we may be selecting patients with more severe disease who happen to come to the office more often as a result of being more symptomatic. There can be subtle but important variations in local practice patterns that can also be difficult to tease out from EHR data. For example, a study may show a higher risk of post-injection endophthalmitis in practitioners using anesthetic gels rather than drops. However, perhaps the gel users always try to hold the eyelids open themselves, whereas the non-gel users always use a lid speculum, and that is ultimately the reason for the association. Selection bias is another potential issue in a real-world study. For example, the incidence of retinal tears after acute PVD may appear to be much higher if that data is coming from retina specialists, just because many of those who are being referred have high-risk features or an already detected tear. But even if we use a broader registry like the IRIS registry, it's important to remember that not all people who have PVD symptoms actually seek care. It may be primarily those with more severe symptoms who show up in an eye care provider's office, which may also correlate with the higher risk. Finally, we have to be very careful about comparing real-world outcomes to randomized clinical trials. These are clearly not apples-to-apples comparisons. It's not uncommon for real-world studies to include patients who might not have qualified for the randomized trials to begin with. Even if the same inclusion and exclusion criteria are used, the distribution of patients with varying severity of the disease being studied may actually differ from the randomized trial. Endpoint measurements are also often different, especially when it comes to visual acuity, as trials use standardized ETDRS protocol refractions, while real-world studies usually do not. Finally, real-world studies often do not follow the same treatment protocol as the clinical trial. So given all the problems and pitfalls with EHR data, why even use it for clinical research? First of all, there are vast quantities of data available in a much richer data set than what is possible from a prospective trial. Second of all, the clinical data from EHRs include a much more diverse patient population in terms of age range, race, ethnicity, socioeconomic backgrounds, and conditions. As a result, there's the potential to study more complex problems, understand the nature of rare diseases or uncommon complications of treatments, and examine outcomes in underrepresented cohorts. Last but not least is that these types of studies can be much more cost and time efficient compared to putting together a prospective study. Thank you very much for your attention.
Thank you, Dr. Shu. Next, we'll have Tom Chula speaking about the ins and outs of specific EHR databases.
Today I'm going to discuss the ins and outs of specific EHR databases. My disclosures are shown on this slide, none of which are relevant to this presentation. I have previously presented and published on clinical practice outcomes in neovascular AMD, DME, and RVO-associated macular edema. I am very excited about the potential for real-world data in ophthalmology. Today I'll briefly cover why is real-world data important, claims data versus EHR data, common current databases, conversion of Snellen and visual acuity, and limitations of EHR database clinical research. Given the ability to scale, real-world data is important for numerous applications, including natural history studies, benchmarking for practice improvement, as well as clinician and therapeutic value-based care, clinical research including retrospective studies, clinical trial site selection, and patient identification, and finally, as providing commercial insights to optimize portfolio allocation and launch strategy. While claims data may be well structured, EHR data provides important clinical nuances and details. EHR data is generally rich with history, exam findings, and treatment details. The IRIS registry is the nation's first comprehensive eye disease clinical registry. All U.S. ophthalmologists Academy members in good standing are eligible to participate in the IRIS registry. These physicians benefit because the system facilitates quality measure reporting for Medicare's merit-based incentive payment system. The IRIS registry includes 79 million unique patients and 571 million patient visits. Verana Health provides analysis of the data in various data-driven products, such as clinical trial site selection and patient identification, as well as insights for industry. Available data includes patient history, exam findings including visual acuity and intraocular pressure, as well as diagnosis. Unfortunately, there's limited ability to query imaging. Another EHR-based database is the Corvitas Vestrum Health Retina database. It includes 2.3 million unique patients and 15 million patient visits from U.S. retina physicians. Importantly, as a retina specialist database, it differs from the IRIS registry, which instead includes all specialties. The Corvitas Vestrum Health Retina database includes a panel of over 350 U.S. retina physicians. It is geographically diverse, and like the IRIS registry, available data includes patient history, exam findings including visual acuity and intraocular pressure, as well as diagnosis. Once again, there's limited ability to query imaging. These EHR-based systems de-identify data and aggregate it in a HIPAA-compliant, secure fashion. Like the IRIS registry Verana Health system, the Corvitas Vestrum Health system provides various data-driven products such as clinical trial site selection and patient identification, as well as insights for industry. Recently, Retina Consultants of America and Retina AI announced a collaboration to develop a real-world evidence US-based database. So far, there have been over 1.7 million annual patient visits in over 200 locations. The formula shown here was used to convert Snellen visual acuity into an ETDRS approximation, but this obviously can't compare to a standardized ETDRS protocol refraction. Finally, I want to point out that clinical research using EHR databases has multiple limitations. These studies are retrospective with limited controls, which cannot be compared with randomized clinical trials. Furthermore, there's limited ability to tailor inclusion and exclusion criteria compared to the explicit criteria in randomized controlled trials. We've already discussed the non-standardized visual acuity assessment, and imaging is generally non-standardized, with limited ability to query that image data. Today we covered some important concepts in EHR-based real-world databases. While there are limitations, given the ability to scale, real-world data is important for natural history studies, benchmarking, clinical research, and commercial insights. Thank you very much for your attention today.
Great. Thank you, Dr. Shula. Next, we'll have Josh Stein speaking on the Site Outcomes Research Collaborative.
Good morning, everyone, and thank you very much for the opportunity to speak today. I'll be discussing the Site Outcomes Research or SOURCE Ophthalmology Big Data Consortium. These are my financial disclosures. So SOURCE is a consortium of academic ophthalmology departments, all of whom are on the EPIC electronic health record system that are contributing data on patients with eye diseases seen at our institutions. My colleagues and I at the University of Michigan have spent a lot of time going screen by screen through the EHR to capture all the relevant information for research and quality improvement projects, including patient demographics, all the structured data from clinic visits, billing codes such as ICD and CPT codes. We have some patient report outcome data, lab test data, pathology data, data from operative reports, and medications. Once we successfully pulled all the data from our site, we've been sharing our scripts with other large academic centers and helping them pull their data, and sites are de-identifying their data and sending it into our data office where we clean the data, harmonize the data. We're able to link in metadata from ocular imaging and diagnostic tests In the future, we hope to add in genomic data and create a pooled resource that researchers at each of the participating sites can use for research and quality improvement projects. Presently, we have over a dozen academic centers that are involved in the consortium. These are active sites that have contributed their data and are actively working with source data. There are another 12 or so sites that are in the process of sending their data into source. And overall, there are several dozen sites across the country that are getting involved in source. So it's a nice geographically diverse group and with a nice representation of patients of different races and ethnicities. In terms of specific data that we're able to capture, for example, all the standard eye exam fields, we're able to parse out all the relevant details such as the optic disc or the macula exam. For billing codes, we're capturing both ocular as well as non-ocular conditions and all the CPT codes for visits, diagnostic and therapeutic procedures. All the details of a surgery, including the timestamps when the patient entered and exited the OR, all the CPT codes, supplies, implants, intraoperative medications, lab tests and results, including hemoglobin A1Cs, all your standard medication, prescription information. And we're able to link data, the clinical data in source to diagnostic test data, including data from OCT, visual fields, biometry, etc. All the data in source is completely de-identified, but we shift the dates so we're able to follow a patient longitudinally over time. There are more than 4 million unique eye care recipients in source, over 19 million office visits, and over 800,000 ocular surgeries, many millions of patients with meds and labs, and over 2 million macular OCTs. Just in the past year alone, the size of source has over doubled in size. In terms of the demographics, you can see that there's a nice representation of racial and ethnic minorities. And the demographics of patients in source are very similar to those in the US Census. In terms of detailed granularity of data, for those who are interested in retinal diseases, you can see these are all the different types of pathology. So if you're interested in geographic atrophy or subretinal neovascularization, we're able to parse out those details. There is a lot of messiness to this data, as some of the earlier speakers have mentioned, and we do a lot of work to try to deal with the messiness. So when a researcher just wants to look at a particular question, they don't have to do a lot of the cleaning on their own. In terms of the diagnostic test data, here's an example. We have over 20,000 patients with 5 or more macular OCTs and over 6,000 with 10 or more tests. More information can be found at our website, sourcecollaborative.org. In terms of use cases, researchers are using it for clinical studies, outcomes research, machine learning and AI, algorithms, quality improvement initiatives, and potential patient recruitment for clinical trials. Here's an example of a study using source data to predict glaucoma progression using machine learning. And this is a recent publication on optic neuritis. There are over 24 researchers working with source data, several large NIH-funded grants and foundation grants using source data. And we are able to link source data to other pots of data, such as social determinant of health data, mortality data, community environmental data. These are the site leads at all of the active sites. And thank you for your attention. Happy to answer questions in the discussion period.
Thank you, Dr. Stein. Next, we have Dr. Wang, the ins and outs of specific claims databases.
Thank you so much, everyone, for being here. Thanks to the organizers for inviting me. So I'll try to cover some very specific claims databases in 8 minutes. I have no conflicts of interest. Okay, in order to understand claims databases and what's in them, you do have to understand what is a claim, right? A claim is a medical bill that healthcare providers submit to the patient's insurance provider in order to get paid for their services. So claims data typically does not contain free text clinical notes, clinical data measures such as vital signs, visual acuity, intraocular pressure, and generally not any information on things like family history, social history, health-related behaviors, unless the claims database has tried to collect some of that separately. So on the right, you'll see sort of a traditional type of form that gets submitted to the insurance, and you can see there's information, patient information, diagnoses, dates and places of service, procedure and diagnosis codes, and the charges that the provider put it. So to cover some very specific health insurance claims databases, we can start with Optum. This is one of the most commonly used insurance claims data sets, and it comes primarily from the United Health Group, which is one of the largest insurance networks in the US. Spans from 93 to the present and contains information on over 111 million lives. And you can access it in a variety of forms. There are some forms that have linked socioeconomic data, such as race, ethnicity, income, education, and so forth. And there's also versions where they have some of the zip code data, for example, 3-digit zip codes. There are also other forms where the data is formatted in a more common data model, for example, the OMOP common data model, which is becoming more common as a standardized method of storing observational health research data. In late 2022, they did make some changes in the terms of the licensing to academic institutions that have made data more difficult to access. So your mileage may vary. The structure of the data is very typical to any large claims data set, so I'll use it as the prototypical example. Different data types are stored in different tables. You can see we have demographics and administrative data in one table, which is one row per patient, then diagnoses and encounters in separate tables, one row per encounter or one row per diagnosis, and similarly medications and pharmacy claims and lab orders in another table. So when you're working with this kind of data, the key to defining your cohort is you have to be able to retrieve the disparate pieces of data that you need corresponding to your particular list of inclusion and exclusion criteria and match them up or merge them between potentially many separate tables to form your own analysis data sets. Another source of claims data is through Truven Health Analytics, which they call their market scan research databases. It's very similar to Optum in that it contains de-identified records of hundreds of millions of patients. And in this case, the data come from large employers, health plans, state Medicaid agencies, and others. And the structure of this data is very similar in that it contains tables for inpatient and outpatient data, medications, labs, etc. Also, you can get cuts of the data set, which include some dental information and some employment related data. Something to keep in mind when working with either of these databases or really claims data in general is that they are very large convenience samples, but they're not nationally representative. They're only privately insured individuals. The data sets don't really adequately represent uninsured folks or people with other types of medical coverage. It can be very good for rarer diseases or rare outcomes because there's enormous power there. It can detect very small effect sizes, but you can only study the diseases or outcomes that are well captured by diagnosis codes, things that you typically only find in free text clinical notes and are not well coded. It's much more difficult to study those patients or outcomes. And then I'll also add a tip that due to the sheer size of these data sets, when doing your analyses on very large cohorts for common diseases like glaucoma, it's very helpful to use a programming language that doesn't load the entire data set into memory. So for example, SAS is a good choice, and many other languages like SATA and R, just load the whole table into memory and then crash your computer and cost slow down. So that's my practical tip for that. So we can't talk about claims without also touching on Medicare, which is a U.S. federal health insurance plan that covers individuals who are 65 years of age or older, and also select individuals who are younger who have a recognized disability or receive Social Security, certain railroad retirement board benefits, folks with end-stage renal disease. So you can see here kind of a estimate of the demographics for Medicare beneficiaries, mostly 65 and up. And the number of publications using this administrative claims database, of course, is rising year over year as well. This database is a little bit special because of the way that the Medicare coverage is structured. There are different parts to it, and nearly all beneficiaries are enrolled in Part A or B coverage, which covers inpatient hospital stays in Part A, and then partial coverage for doctor's visits, outpatient data in Part B. And about 70% were enrolled in Part D, which covers more prescription drug medication. There are some folks, about 30%, who are enrolled in Part C plans, which is similar to your traditional health maintenance organization or HMO plan. It's a type of kind of Medicare plan that's offered by private companies that contract with Medicare to provide the Part A and B benefits and add some more on top of that. So this is like if you get Medicare Advantage or through Kaiser, for example, that would be Part C. So depending on the different parts, the tables come corresponding to those parts. So you can get inpatient files, skilled nursing facility files, home health agency files, hospice files through Part A, and then outpatient and durable medical equipment and home health in Part B, and of course, prescription drug and med files. Finally, I want to touch on the last set of research databases, and I'll mention these because they're really easily accessible compared to Medicare, Optum, and Truven. These are a set of research files available through the Healthcare Cost and Utilization Project, or HCUP, which is run through the U.S. Agency for Healthcare Research and Quality, or AHRQ. You can purchase them directly through the AHRQ website by year, and it's relatively cheaply available. And there are different data sets which cover different aspects, like, for example, inpatient utilization, ambulatory surgery, emergency department visits. And basically, these are sort of government designed samples of these different types of healthcare events. So, for example, the National Inpatient Sample is the largest publicly available all-payer inpatient healthcare database, and it's designed to produce U.S. regional and national estimates. So it's not just a convenient sample. There's a sort of formal sampling strategy here where you can get national estimates. And then inpatient utilization, access, costs, and outcomes. Doesn't matter what insurance the patient had or not. And it's also very large. For example, the inpatient sample covers around 7 million hospital stays per year. So of course, as ophthalmology, we're mostly an outpatient specialty, and some of these files are kind of only peripherally useful for our research, but nonetheless, some groups have found really interesting analyses to do with this data, particularly in the realm of emergency department visits. So that is the end of my quick coverage of various specific claims databases. Hopefully I've given you all a starting point that can jumpstart your process towards working with this type of real world data for your research. I'm happy to answer any questions in the panel.
Great. Thank you, Sophia. All right, we're going to open up the discussion now. Seems like quite a few people are still waking up. The question answers are not flying in, but I certainly have a few questions that I'd hope to get answered from you guys. Unfortunately, Dr. Xu, Dr. Chula were not able to be with us in person for the panelist discussion. So Sophia, I actually wasn't aware of the Nationwide Ambulatory Surgery Center database. And it looks like that's just hospital affiliated. So a privately owned ambulatory surgery center would not be part of that data set, correct?
I think that's right. And so that's why there are some sort of, limitations for our specialty in using some of these collected databases. But for example, the emergency department database has been good for looking at things like, trends in ocular trauma presenting to the emergency department across the country. So you kind of have to look at it and see whether it's suitable for what you're looking for.
So I had a question, maybe that I could have Josh, Sophia, and Durga weigh in on, because you both, Durga's kind of worked a lot on Verana. Josh, you've obviously worked a lot on your database, and Sophia, all the other claims ones. So let's say we're doing a study on COVID-19 vaccines and their ophthalmic outcomes. Remember back in the day, that was a big deal when everyone thought that they were causing potentially a CRVO or CRAO. So why don't you each, in your own words, tell me why you think your database might be the best or may have limitations in the analysis? Because I think it was an interesting problem to solve. We actually used Trinetics as our database we used for that. And again, that's not perfect either. That wasn't discussed today. Trinetics is a collaborative of multiple academic centers which are contributing data through their EHR. They're non-EPIC and EPIC related, so they're all different academic centers. But I'd love to hear each of you comment on maybe that dilemma. How about Sophia to start with?
Sure, I'll start. Well, when you have an emerging problem or an emerging, let's see, hot topic, a new disease, new surgery, for example, or a procedure that you want to study, claims databases, there is a lag in the kind of data that is included. So, for example, if you're going to study COVID vaccines, you're not going to get that data until a year or more out from introduction, right? So it doesn't trickle in. So that's one limitation. And then if you're interested in particularly in visual outcomes, there's not going to be any visual acuity, for example. You're not going to have fine-grained eye exam findings. You're only going to be limited to whatever was coded. So, if you think that the outcome is an existing diagnosis, like that will be well coded, that would work. But if it's going to be a new disease, a new manifestation, a new something or other that isn't well captured by existing ICD codes, then again, that's not going to be an ideal situation for that kind of study.
I can go next. I think Sophia kind of mentioned some of the issues that are probably present in all these data sets. The main one is it takes some time for the data to come in and to get processed and made available to researchers. So for a problem like COVID at the time, we were dealing with the pandemic, I don't think any of these resources are quick enough to get the data out there to researchers to be able to do it. I know there was a specific COVID data set that was put together, and there were a lot of resources and a lot of people working together to be able to pull that off. But I think it's quite challenging. I think the other issues is how well we're able to capture which patients have COVID and which don't. We don't have all the COVID tests coming into our databases, so patients may or may not. It's hard for any of these data sets to know which patients have COVID. Probably the ones with more severe COVID are going to show up at our health systems and get captured. Because Source is capturing data at large academic centers, patients who are really sick from COVID are probably going to show up at those facilities. So I think that would be an advantage of trying to use a resource like that. But I think there are trade-offs. The data in Source goes through the end of 2022. So at this point, we're now able to look, pre, during, and pre pandemic, during pandemic, and post pandemic. But we weren't able to do that in 2020, obviously.
I think this is a great question. And I actually think in ophthalmology, we have to think outside of the box a little bit more than other specialties when it comes to real world data, because we look at outcomes that aren't easily captured a lot of times in claims. For example, oncology, cardiology, they can just look at things like hospitalizations and mortality. We're looking at vision. And especially in the question that you asked, Rishi, I think there's a need to really actually leverage multiple data sources to get the answer that we want. So agree with what has been said about data lag. I think to get some of the answers about outcomes for, RAO or RVO, we would need an EHR registry, but I almost think that it would need to be linked to a vaccine registry and claims data potentially, to really have a high fidelity way to answer the question. And I think that would be the best way to go about it.
Yeah, I think that highlights the dilemma, right? Is that we're all looking for directional kind of relationships, but some of the databases you all highlighted potentially have those directional databases that might help us. It doesn't mean that there's truly an association, more so that we're trying to look for the directional nature of these arguments that we're having. So,
Rishi, I know you didn't ask me, but if I could just pop into
yeah,
it.
please go ahead. Yeah,
The way I like to think about real world data, and that can be probably more so for claims, but even into the EHR set, is the things that get paid well are going to be best captured. And specific to the COVID question and or COVID vaccinations, when you have so much at-home testing, that's obviously not going to be paid well, so it's not going to be captured real well, or difficult to capture. And then also, at least early in the vaccinations, when the government was paying direct to pharmaceutical company or pharmacies to actually administer the vaccinations, a lot of that's not going to make it necessarily into the EHR or to the claims data. I do think as we get the next wave, when government is no longer directly subsidizing it and it's more on the insurance companies, a lot more of that's going to make it in, and we'll be able to get a lot more information on it.
great comments. Thank you. I didn't mean to leave you out. That's a great.
No, not a problem. Josh, if I could ask you a question, what, we heard from Jason Shu a lot about some of the issues that come up with EHR data. What do you feel like are the next steps in improving a lot of the things that Source are doing to try and eliminate some of those, or at the very least reduce some of the issues with EHR data?
Yeah, I mean, I think as he had mentioned, there's a lot of messiness to this data, and it really takes a lot of time and energy and clinical input to try to deal with that messiness. I mean, there's structured data fields, and then there's unstructured or free text, and the free text is even more messy. But I think that it really requires people with informatics backgrounds, along with those with clinical backgrounds, to work together to deal with that messiness, to understand, missing data issues, that and to look for ways to link data sets, to come up, to get a more holistic view of our patients and everything affecting them.
And do you think regular use of natural language processing is very far off, so that we can start incorporating some of the assessment and plans into our research?
I think that we'll start doing that. The software is getting better and better. I think the biggest challenge right now is that there's the risk of PHI being present in the free text notes, and a lot of health systems are wary and hesitant to share free text. But I think as we come up with better tools, we'll be able to do that. So I'm pretty optimistic we'll be able to do that pretty soon.
Great, thank you.
Maybe to jump in a little bit on the natural language processing side of
Sure.
things, I think there are, the tools are getting better and better, that's definitely sure, but the challenges still remain about, if you want to do a study that's linking a specific disease or piece of history to a particular outcome, researchers will want to know that you've detected or captured that information from the text accurately. And the challenges there are, is it present or was it historical? Is it about the patient or is it family history? Is it present or is it actually negated? So it's not enough to just be able to pick up the term. You have to find all of those things in the context too, and that's still a challenge. So if researchers want to be really sure about that one piece of information, you can't get around having to do some validation for that.
Great, very helpful comment. Thank you, Sophia. I think we're getting close to moving on to our next session.
Yeah, we can.
So
Thank you.
thank you, speakers.
Great.
Thank you.
So I'm going to lead off the next session. Thank you all for joining. So just to say a few comments about how this all started, we, Durga Borkar and myself and Brian Vanderbeek got together and realized that a lot of us are doing big data studies. And is there a need to better understand sort of some of the parameters about how we can collect this data, what databases are available, and then also show the applications of it, because I think we're seeing so many studies come up into our field that are so valuable. And so I'm going to lead off this session just showing you some real world application of these data sets, and it's on neovascular AMD. And the first talk will actually be by Viral Sheth. He'll talk about the key findings from the Voyager study.
Thank you. I want to thank the committee for allowing me the opportunity to present some data from the Voyager study here today. Here are the financial disclosures of the steering committee for the Voyager group. So what is the Voyager study? What's the rationale and what are the key outputs we're looking for? Well, in order to go into that, it's kind of important to discuss a little bit about the genesis of this Voyager study group and the study itself and the study design. So we know that treatment outcomes with antivascular endothelial growth factors are often poorer in clinical practice than in clinical trials. We know that the reason for this is largely unknown due to incomplete real-world data collection. We know that there are factors that may contribute to this, including inadequate treatment frequency and inability to replicate clinical trial protocols in real life, longer-term follow-up, and greater patient diversity in the real world than what we see in clinical trials. To address this evidence gap, the Voyager study was developed to better understand why real-world outcomes don't necessarily meet clinical trial outcomes in retinal disease. The Voyager study aims to explore long-term real-world effectiveness and safety of faricimab in its improved indications, in particular neovascular AMD and diabetic macular edema. We want to gain insights into the real-world treatment patterns and factors driving clinician treatment decisions. And we want to provide a novel investigator interface for healthcare providers to gain a complete picture of individual responses to optimize treatment. And we're going to do this on a global scale with sites all across the world. We're going to gather image data as well to validate key anatomical features that influence visual outcomes. This study will provide a unique opportunity to see how faricimab is being used in the real world and provide meaningful long-term data and resources to optimize its use in the real world. The Voyager study is a non-interventional, prospective, multinational, multi-center study. We're looking at adult patients being treated with faricimab for neovascular AMD or DME. And we're looking at patients that potentially could have been in prior Roche studies or interventional studies, but can't have been in a study within the last 28 days. There are minimal inclusion and exclusion criteria. We're trying to capture all comers as much as possible to allow for a broad range of patients to be assessed in this study. Patients will be followed for up to 5 years depending on when they enter the study. Visual acuity imaging assessments will be performed as per routine clinical practice, with analysis being performed at specified time points with an appropriate window period. This presentation in particular is from about 6.5 months of data collected between mid-November 2022 to early June 2023. The results include 220 eyes with neovascular AMD from 174 patients and 107 eyes with DME from 69 patients. Here are the baseline demographics. You can see that overall, both neovascular AMD and DME populations were largely comprised of white American non-Hispanic patients, skewing slightly older in the neovascular AMD population and slightly fewer females in the diabetic macular edema population. Almost all neovascular AMD and diabetic macular edema eyes were treated with faricimab or an anti-VEGF prior to enrollment in Voyager, which is not a surprise. So the early patients that we've collected data on were previously treated patients, and many of them were already on faricimab when they rolled into this study. Roughly half of neovascular AMD and diabetic macular edema patients had received more than 25 injections over 46.4 months. The most recent prior injection interval was roughly 2 months on average prior to enrollment in this study. Patients who switched from another anti-VEGF to faricimab at enrollment into the Voyager study were included in the interim analysis of visual acuity and CST. Results from baseline to month 3 in neovascular AMD and DME switch patients show slight increases in visual acuity, which you can see here. In terms of CST, we saw a rapid decrease amongst patients who switched from anti-VEGF to faricimab from baseline to month 3. And these results are consistent across both indications for both neovascular AMD as well as diabetic macular edema. Most physicians participating in this trial at the time of interim analysis were retinal specialists. 61% and 39% of physicians tolerated fluid in neovascular AMD and diabetic macular edema, respectively. Future data is going to provide information on what type of fluids physicians typically tolerate. We're going to dive a little bit more into that data and hopefully get more granular. The preferred treatment regimen for both indications was treat and extend. A larger percentage of physicians treat on a case-by-case basis in diabetic macular edema. So in summary, the Voyager study is a non-interventional, prospective, multinational study assessing the long-term real-world outcomes of faricimab. Results from this interim analysis largely include patients in the U.S. who had received prior anti-VEGF or faricimab treatment. We expect that to evolve over time as new countries come on board and as we get more new patients into this study. Mean visual acuity increased and CST showed a rapid decrease amongst patients who switched from anti-VEGF to faricimab. No new safety concerns were identified yet. Treat and extend was the preferred treatment option for both indications. Patients seem to tolerate fluid in patients with neovascular AMD and diabetic macular edema, respectively, but we're going to get more granular, as I mentioned before, as that data matures. Data from the Voyager study will help support an in-depth understanding of factors affecting treatment outcomes for faricimab in the real-world data, and hopefully you'll have more data to come soon. Thank you.
Thank you, Viral. So that's a great talk and really summarize some of the ways we're doing post-marketing studies in these drugs and looking at these drugs over time from a safety and efficacy standpoint. Please feel free to submit questions in the chat box. We'll get to them at our panel session coming up. Our next talk is actually going to be by Dr. Andrew Bush-Fege. He's going to talk about injection frequency and visual acuity outcomes in exudative macular degeneration. Andrew?
Thanks, Rishi. I'd like to share with you our experience looking at outcomes of intravitreal anti-VEGF therapy for neovascular AMD in routine clinical practice. And okay, so here are my disclosures. So dosing approaches in clinical trials are certainly varied. We're used to regular monthly or bi-monthly treatments with all the studies listed in green. Then there were less frequent dosing, such as quarterly dosing with PEER, SAILOR, and EXCITE study as needed, treat and extend. So lots of different ways to approach the treatment necessity in neovascular AMD. We know from long-term experience with the retrospectoscope that when we look at patients who've been treated over a long period of time with wet AMD, that deviations from very consistent dosing have been associated with a decline of those initial visual gains over time. And you can see that after the dosing strategies have been varied after a period of time, such as shown in the Horizon study with ranibizumab and the CAT study. Again, you can see relaxation in the regimen resulted in a diminished visual gain over time. And that vision can largely be maintained when patients continue on more consistent dosing, as was done with the modified quarterly dosing in the VIEW 1 extension study with aflibercept, where, yes, there's still a diminishing level of visual gains over time, but the magnitude of that diminution is less magnified. What about after we say, okay, let's lessen the stringency of the retreatment intervals, but then let's get back on track with more frequent intervals, as was done in the Horizon study. When you look at that approach, although the slope diminishes, there's not the regaining of visual acuity to the level of the other arms of the study, so that, if you do this for a long period of time, you just cannot get back to where you would have liked to have been. On a similar note, when you look at long-term injection frequencies in patients who had really frequent injections, like every 1 to 2 months, as was done in Peden et al. Study circled in blue in the upper right-hand corner, you can see that those patients weren't getting just like 4 or 5 injections per year. On average, they were receiving close to 11 injections per year. And you can see the visual gains associated with that study were close to 3 lines of vision, suggesting that more frequent dosing was associated with better visual acuity outcomes. And this is borne out in multiple different clinical studies where very frequent dosing was, in fact, associated with better visual outcomes, not just in wet AMD, but also in diabetic macular edema, as shown here. And again, the focus of this talk is on wet AMD, but just to show you that this is something that also occurs in other disease states affected by VEGF. So what we decided to do is to look at the Vestrum Health database to evaluate visual acuity outcomes following treatment of neovascular AMD or DME in patients receiving anti-VEGF agents in routine clinical practice with at least 2 years of follow-up. We looked at the Vestrum electronic medical record data from over 251 retina specialists, and patients had to have their first injection between 2012 and 2015. And we divided the groups at baseline into those who had less frequent dosing, less than 6 injections per year, or more frequent dosing, 7 or more injections per year. When we looked at the neovascular AMD cohort, initially it was over 200,000 patients that were evaluated, but when we applied all the different criteria that were necessary for good data analysis, such as visual acuity metrics and follow-up, we had over 8,000 patients that were evaluable. And this comprised of about 1,840 patients who had less than 6 injections and about 6,287 patients who had 7 or more injections. And you can see the breakdown between the visual acuity subgroups in the bottom rows, with approximately 40 to 50% of patients being between 2040 and 2100. The top line data here is that, shown in yellow, the group that had 7 or more injections per year gained about 6.4 mean visual acuity change letters at year 1, compared to just 2.1 in letters gained for the less than 6 injections per year. So what was it? Was it really 7 injections exactly, or 6 injections in each of these groups? Well, if you look on the left, you can see that the less than 6 injections per year group had approximately 4.5 injections per year on average, whereas the more than 7 group had roughly 9.1 injections on average. And how did this look over time? So with the less than 6 injections per year, although they did okay, there was a little bit of a gain. When you look at the more than 7 injections per year, you can see a clear separation. It is true that they started off at a slightly higher level of visual acuity, but if anything, that would have made it more difficult for them from a ceiling perspective. So we can see that there's nice separation between these two, suggesting that greater visual acuity gains were associated with more frequent injections. And when we look at this over time, we can see that in 2012 on the left and 2015 on the right, and the intervening years in between, that there was a steady increase in the number of injections. We believe that this was associated with a greater prevailing awareness of the fact of the hypothesis of this study, that more injections is associated with better visual outcomes. And you can see here, when we look at the proportion of patients, that by 2012, it was really an 80-20 split compared to a 75-25 split. By 2015, I should say 80-20 split, but compared with 2012, when it was more of a 75-25 split, but the trend being towards more frequent injections, such that by 2015, there was about 8.25 injections on average. So consistent with the results of established clinical trials, also now in routine clinical practice, these big data sets can provide us with the evidence that maintenance of visual gains was in fact associated with more frequent anti-VEGF injections in patients with neovascular AMD. Patients with neovascular AMD were more likely to receive more frequent injections, at least 7 per year, rather than fewer, less than 6 or less, during the first year of treatment. And annually, a trend was observed towards more frequent injections during the first year of treatment in patients with neovascular AMD. We found a very similar result in diabetic macular edema, but for the purposes of this session, I restricted my comments to AMD. Thank you.
All right, great. Thank you, Andrew. Appreciate that talk. That's going to be great. And we're going to have you at the panel session in just a moment. And we're going to be discussing that talk. There's so many interesting questions that came out of that alone. So that's really great data to show. All right. So Mike Singer. Hi, Mike. How are you? We're going to have you talk about the Truckee study, the real-world efficacy and safety of faricimab and neovascular AMD.
Thanks, Rishi. We're going to talk about the Truckee study, which is a real-world study of looking at faricimab in patients with neovascular AMD. Next slide. All right, here are my financial disclosures. What's important to understand is, although I have lots of consulting fees, this was a non-sponsored study. Essentially, there were no pharmaceutical companies behind it. CRO services were provided by Vial. So you can see from that map that went by really quickly that essentially this is a group of private practices throughout the United States who all volunteered to pool their data to show how faricimab works after initially had been approved, to get some real-world data. Because obviously, as you've heard from all the other speakers, real-world data is a lot more diverse and can be a little more messy than clinical trials where people are well-regulated in terms of admission. So what did we do? We wanted to evaluate the efficacy and safety of faricimab in real world. We did both treatment naive and previously treated patients. We got demographic data, previous history, efficacy, using vision, CST, real world, retinal fluid, pigment epithelial detachment, want to see if it works, durability and safety. We have 2,622 eyes of 2,212 patients were treated in our study population. 11,000 injections were administered. Follow-up was available for about 2,300 eyes. Follow-up after 6 injections were available for 406 eyes. And here are your basic demographics. Important to understand that most of the patients, as you can see, were previously treated, with only 5% being treatment naive. The vast majority of patients were switched from aflibercept versus other anti-VEGF medications. The mean age is what you'd expect. So what was the efficacy after an injection of patients who were treatment naive? And you could see that faricimab did a great job in terms of decreasing CST. It did increase vision and did decrease PED height. Looking at a different set of population, the switch patients, which are typically the patients that we treat when we first take a new medicine, and faricimab was very good in both increasing vision, decreasing OCT thickness, and decreasing PED height. If you break the switch patients down to aflibercept, which was what typically people jump to, you can see as well that faricimab was able to gain vision, decrease CST, and decrease PED height. In addition, when we look at the interval is slightly longer than before they were treated. Initially 45 days and goes up to 49 days. So when you look at the different things in terms of fluid, what happens in terms of fluid when you change these patients to faricimab? Well, you can see regardless of what you look at, whether you look at all switch patients, treatment naive patients, or aflibercept patients, aflibercept who were treated with aflibercept, obviously their fluid went down. Once you put these people on faricimab, regardless of what group you fall in, there's a reduction of intraretinal fluid and subretinal fluid, regardless of which group you fall into. Looking at the efficacy after 6 patients, so this is a smaller cohort with a longer period of follow-up, you're still able to maintain increasing vision and decreasing CST. When you look at faricimab patients who were switched from aflibercept, you can see as well, you could see that it did do a good job in terms of decreasing CST. The change in vision was under 1 letter. Next, there we go. Safety is one of the things we always worry about when we put people on new medications. And obviously in 2023, it's now top of mind. You could see very clearly that there was a small amount of intraocular inflammation, but it's 0.02%, and endophthalmitis 0.04%. However, what's really important to understand is what keeps you up at night we didn't see. There was no retinal vasculitis or no retinal artery occlusions in this patient population. So the good news is, although there's a small amount of safety effects, they're pretty minimal and way less than what we've been worried about when we start other medications. So here are some cases. There's some good cases. My dear friend Arshad Kanani, here's a patient who essentially were treated before they aflibercept about 30 days. You give a faricimab, they go from 36 letters to 56 letters. Their CST goes from 468 to 398. And essentially, this is 33 days after faricimab injection. Here's another case where we're looking at patients as well. 31 days ago, they got aflibercept. Their vision was 20/40. They're now 20/30. They gained about 5 letters, and they lost, somewhere in about almost 100 microns of fluid. Here are cases where you look at intraretinal fluid. Here is a patient been, treated 37 days before, has chronic subretinal fluid and intraretinal fluid after one shot. The fluid has gotten better, the vision has gotten better, and the CST has improved. So in conclusion, a real-world setting, faricimab continues to demonstrate rapid improvements in all anatomic parameters in 2,300 patients who were both treatment naive and previously treated. 25 to 30% of these real-world patients had complete resolution of intraretinal fluid and subretinal fluid after one injection. 50 microns of CST was achieved after 6 injections in patients who were switched from aflibercept. Statistically significant CST reductions were achieved in patients after 1 and 6 injections. And over 11,000 injections were performed with a very low rate of IOI of 0.02%, a rate of endophthalmitis of 0.04%, and what's most important, no retinal vasculitis or retinal artery occlusion. Thank you for your attention.
Thanks, Mike. It's a great presentation. We're going to be hearing from you again in the panel discussion. Again, for those watching, please feel free to ask questions. I see some of them trickling into the chat, and that's good to see. And we'll get to those at the panel discussion. So our next talk is going to be by Anita Barakarian. She's going to talk about the characteristics and outcomes of neovascular AMD patients managed in the U.S. routine clinical practice, analysis of the IRIS registry database. Anita?
Yes, thanks, Rishi. My co-authors and I would like to thank the meeting organizers for the opportunity to present our talk entitled Characteristics and Outcomes of Patients with Neovascular AMD Managed in U.S. Routine Clinical Practice. I have no financial disclosures. So in clinical trials, patients with neovascular AMD treated with anti-VEGF therapy demonstrate improved visual acuity and anatomic outcomes. However, challenges in managing neovascular AMD in routine clinical practice may hinder achieving optimal patient outcomes. Understanding the relationships between different patterns of neovascular AMD management, baseline patient characteristics, and their impact on visual and anatomic outcomes can help identify gaps in care leading to suboptimal outcomes. So this analysis evaluated real-world management of neovascular AMD, visual outcomes at 1 year, factors predicting sufficient treatment, and the impact of treatment sufficiency on visual outcomes as captured in the AAO IRIS registry. All right. So this retrospective analysis of the IRIS registry included treatment-naive eyes with neovascular AMD diagnosed between January 2013 and December 2019 with best-corrected visual acuity better than 2400 and patients older than 55 years. Eyes were excluded if they had DME, RVO, or diabetic retinopathy, or received anti-VEGF injections between 8 and 180 days before neovascular AMD diagnosis. Actively treated eyes received anti-VEGF injections within 3 months of diagnosis and then were categorized as sufficiently or insufficiently treated. Sufficiently treated eyes received more than 7 injections in year 1, and the cutoff of 7 injections comes from recent studies, as was nicely depicted in the previous talk by Dr. Mashvegi, that patients receiving at least 7 injections had better visual acuity gains compared to patients who received less injections in year 1. So around 60% of actively treated eyes were sufficiently treated. So key outcomes examined in this retrospective analysis included anti-VEGF injection frequency and inter-injection intervals, change from baseline in BCVA at year 1, the baseline factors associated with sufficient treatment and visual outcomes at year 1, respectively. Logistic regression and linear regression were used in our analysis. Baseline characteristics and management experience. So baseline demographics were similar between the two groups, and the mean BCVA was around 61 letters between the sufficiently treated and insufficiently treated group. Insurance type and treating physician specialty were also similar between the two groups. Most patients had Medicare insurance and were treated by a retina specialist. So the mean number of injections was around 8.9 for the sufficiently treated group versus 4 injections for the insufficiently treated group, and the difference was significant. And the duration between injections was around 78 days for the insufficiently treated group, which was numerically greater than the sufficiently treated group. Association between baseline factors and treatment sufficiency. So the odds of receiving sufficient treatment were lower for older patients above the age of 85 and for those with baseline visual acuity better than 20/40 or less than 2200. And the odds of receiving sufficient treatment were lower for non-white, Hispanic or Latino, non-Medicare insured patients or Medicaid patients, and for those seen by a non-retina specialist. Year 1 visual gains and associated baseline factors. So the mean change in BCVA from baseline at year 1 was 3.4 letters for the sufficiently treated group and minus 0.1 letters for the insufficiently treated group, and the difference was significant. The observed visual acuity benefits were larger in patients with worse baseline BCVA, and in each BCVA subcategory, those who were insufficiently treated had lower visual acuity outcomes compared to the sufficiently treated group. Younger patients and those with worse baseline BCVA had larger visual gains when receiving sufficient treatment, while Medicaid patients had smaller gains. For example, the mean change in BCVA for Medicaid patients was 2.6 letters lower compared to Medicare patient when all other characteristics were held constant. And the same trend was seen for the insufficiently treated group. So the proportion of patients with at least 15-letter gain or loss in year 1 and associated baseline factors was higher for sufficiently treated group that gained at least 15 letters compared to the sufficiently treated group, and the insufficiently treated group had higher odds of at least 15-letter loss compared to the sufficiently treated group. So looking at these numbers, patients who were sufficiently treated had 66% higher odds of at least 15-letter gain and 35% lower odds of at least 15-letter loss when compared to the insufficiently treated group. Younger patients, when sufficiently treated, had higher odds of at least 15-letter gain, and with each 10-year increment increase of age, the rate of at least 15-letter gain decreases. And patients with worse BCVA, as seen here, had higher odds of at least 15-letter gain when sufficiently treated. Black or African American had higher odds of at least 15-letter gain when sufficiently treated, and Medicaid patients had higher odds of at least 15-letter loss when sufficiently treated. And the same trends were also seen for insufficiently treated groups. When looking at sufficiently treated patients, patients had 14% higher odds of at least 15-letter loss when seen by a non-retina specialist, and 18% higher odds in the insufficiently treated group was also seen for patients treated by a non-retina specialist compared to a retina specialist of 15-letter loss. So patients treated by a non-retina specialist versus retina specialist were more likely to experience vision loss regardless of being treated sufficiently or insufficiently. So in conclusion, a substantial number of newly diagnosed, actively treated eyes with neovascular AMD were insufficiently treated with worse visual outcomes at year 1 compared with those sufficiently treated. The observed visual acuity benefits were larger in patients with worse BCVA. Age, baseline BCVA, race, ethnicity, insurance type, and treating physician specialty impacted neovascular AMD management. Patients treated by a non-retina specialist were more likely to experience clinically significant vision loss. These findings may help clinicians identify gaps in care leading to suboptimal outcomes during management of neovascular AMD. Thank you.
Great. Thank you for that presentation, Ida. Really great. So we're going to get to these panel discussions in a moment. Please keep asking the questions. They're coming in nicely. A lot of great questions that we're going to handle in the panel upcoming. So thanks again, Anita. All right, Farina, you're going to speak. Farina Ali is going to speak on far retina studies. Thank you, Farina, for joining.
Thank you so much. So good morning, and thanks for this opportunity and for putting together this really wonderful meeting. I'm pleased to share this work on behalf of the team. You can see our financial disclosures listed. Let's see here if I can, oh, here we go. All right, so these are our financial disclosures. So as we know, faricimab was approved over a year ago for both the treatment of neovascular AMD and diabetic macular edema. And actually just yesterday, it was approved for the indication of retinal vein occlusion. As has been mentioned, studies are ongoing, collecting real-world data on early treatment patterns and utilizations, 2 of which are physician-led, including the Truckee study that we heard about from Dr. Singer and the Voyager study from Dr. Seth, with multinational for patients treated for neovascular AMD and diabetic macular edema. So the FAR Retina study is designed to understand the real-world experience and outcomes with faricimab, and I'll be describing the AMD cohort and the results there. So we utilize the IRIS registry, as has been discussed earlier in this meeting, including patients with a documented diagnosis of neovascular AMD receiving at least 1 injection. And for the extension analysis, at least 6 months of follow-up and at least 4 injections were received, and extended injection intervals were defined as greater than 6 weeks between injections. We do know, of course, the limitations of EHR-derived patient data that was discussed so well by Dr. Xu in terms of visual acuity, lack of imaging, and physician-level recommendations. And so you can see here how our cohort was defined as follows: a history of neovascular AMD on indexing, at least 12 months of data available prior, breaking down into a large majority that were prior treated, but also a smaller subset who were treatment naive, for a total of over 17,000 eyes. Here we see that the baseline demographics, as listed here, were predominantly female, white, and Medicare recipients. So we saw that 94% of neovascular AMD eyes treated with faricimab were previously treated with anti-VEGF agents in the prior 12 months, on average 7 injections in the prior year, 6 weeks apart on most recent interval. The majority, as you can see here, 67%, were switched from aflibercept. And for those with at least 6 months of follow-up, approximately 6 to 7 injections were performed, both prior treated and treatment naive patients. So looking at and using our definition of faricimab interval injection extension as an injection more than 6 weeks from the prior injection, we found that in the prior treated patients, almost 70% achieved an extended interval, almost 55% of which extended within the first or second injection. For the treatment naive eyes, we found 67% had an extended interval, of which 43% extended within the first or second injection. we saw that 49% of previously treated eyes and 37% of treatment naive eyes initiated faricimab with vision of 20/40 or better. And among those eyes with at least 6 months of follow-up, after 4 injections of faricimab, vision remained stable from baseline in previously treated eyes, and vision gains were observed in treatment naive eyes with a mean gain of 2 letters after 4 injections. Now, this is a patient case to give us some context here from Dr. Lang at Stanford. So an 80-year-old white male with bilateral neovascular AMD. This patient was Q7 week maintained in their right eye, Q9 week in the left eye after a history of multiple prior anti-VEGF injections. And the patient was switched to faricimab and was able, Dr. Lang was able to extend this patient out to Q16 week intervals in both eyes while maintaining good vision and good anatomy, as you can see here. And so these specific examples really show us that the real world anatomic outcomes align with the confidence that we see at the population level in physicians who are performing rapid treatment interval extension for their patients once they had access to this treatment. So in summary, FAR-RETINA is the largest real-world data study currently ongoing for faricimab, with over 28,000 eyes treated with faricimab, over 22,000 for the treatment for neovascular AMD, and over 17,000 that were included in the FAR-RETINA AMD cohort. More than 3/4 of the previously treated eyes had switched from aflibercept with maintenance or improvement in vision that was seen. About half of eyes extended quickly to a longer dosing interval, 55% of previously treated eyes and 43% treatment naive extended within the first 2 injections. So FAR-RETINA AMD and DME are the largest ongoing real-world studies of faricimab, and additional follow-up analyses are planned as the data continues to grow. So thank you very much for your attention.
All right, great. Okay, thank you, Dr. Ali, for that wonderful presentation. We're going to have all our panelists join us for this Q&A. So, conclusion from a lot of your talks, more injections matter, and we need to do more of them, but then we start to see some data, at least a light at the end of the tunnel, maybe in Mike's talk and Dr. Ali's talk about faricimab. Give us your thoughts first, Anita and Andrew. Is that sort of the takeaways you kind of found from your discussion? Then we'll switch over to Farina and to Dr. Singer as well.
Yeah, you hit the nail on the head there, I think, Rishi. Basically, at least with the sort of first generation anti-VEGF agents of regular dose aflibercept, ranibizumab, and bevacizumab, we see that a trend toward better visual acuity gains is associated with more frequent injections, especially in the first year of therapy. And certainly the opposite is also true. So if we're doing less frequent injections, we're seeing a greater chance for loss of vision. And I think the clinical trial data really shows it the best and most convincingly when you see those inflection points. It's one thing to say, well, yeah, you on average did less frequent injections, but when you started doing less frequent injections at a specific point in time in a prospective clinical study, and then you see that change in the slope of the visual acuity curve, that's very convincing. And then when we match that up with what we see in these real world studies, it lends further credence to that hypothesis.
Yeah, great. How about you, Dr. Abarikian?
Yes, the studies have shown that real world data is different than clinical trials. So at least we try to inject patients as much as we can, bring them in. And as seen, when the inter-injection interval is larger in the insufficiently treated group versus the sufficiently treated group, visual acuity goes down. So this is a direct correlation between what we see in real world and in our patients in clinical practice. And this is especially seen in year 1. Progressing into year 2 and year 3, the changes may be different as the disease calms down. So, as Dr. Mashvegi said, it's more significant for the earlier anti-VEGF injections, whereas those that last longer, maybe the trend may change soon.
Great. Okay. And then Mike and for Dr. Ali, you presented topics about the newer agents. what benefit are we seeing right off the bat in some of these early studies in real world?
So basically, what we're seeing in these early studies is that there's still potential, right? We think these people have finally, we had maxed out on using first generation medications, typically aflibercept, and the vast majority of people who were in the Truckee study were switchers from aflibercept. And even after one shot, they were able to decrease OCT central subfield thickness as well as intraretinal and subretinal fluid to show very clearly that there's still potential for improvement. Obviously, we know vision and OCT are not always correlated, and vision definitely lags, and especially in these eyes where essentially in AMD, you've got older photoreceptors with multiple treatments, it's harder to gain the vision back, but there's still potential visual acuity improvements, although they were more numerical. So again, not to give up on these patients, and obviously by switching them, we may be able to gain some extra potential we didn't think of.
Yeah, and as Dr. Singer highlighted well in the Truckee study and in general, we know that with our newer agents, a lot of times we're using them with our more difficult to treat patients. And so we kind of understand how they work, but as we transition to more of our treatment naive patients, we will be able to get a better sense for if we see something different with this newer generation of medications in terms of how many treatments and what sort of correlation that accounts for in terms of visual improvement in an annualized fashion as compared to the data presented by Dr. Moshfeghi and Dr. Barikian with some of the older agents. So I think we're in an exciting stage. The far retina studies, using the IRIS registry obviously doesn't give us some of the granularity that we can see with some of the Truckee data in terms of specifics and anatomic improvement, as well as robust effects on individual level. However, it does tell us that overall, we can surmise that physicians are confident in the utilization of this drug and extending their patients more readily than we've seen in prior large data cohorts for first generation agents. So it's an interesting transition.
Yeah, great comments. And so I'd just like to ask this question, I think, of all of you. I think some of these studies are plagued with visual acuity measurements. And clearly there's no refractions done in all of these trials you were talking about, or at least the data that was there. How do you resolve some of that commentary about visual acuity, and is that truly a limitation in these analyses? Let's start off with maybe Anita, and maybe you can comment on your study about the visual acuity impact and things like that for that.
Yes, definitely. We don't have a standardized measurement for visual acuity, and that creates a problem in analyzing our data. A lot of studies actually focus on OCT data and try to avoid visual acuity outcomes just because the data is very scattered and can be unreliable. Yet again, maybe mean BCVA is good. Sometimes if we can't take EDTRS, that would be like the best standard. But usually we try to focus on the best corrected visual acuity with the newest refraction that the patient has. So I think this is the data that actually can be provided with good outcomes.
Great. Anyone else want to comment? How about Dr. Ali? I know you had, this came up in the far retina studies as well. And we, looking through the data, really making sure that we were adequately classifying visual acuity gains has been problematic. How do you kind of resolve that?
Yeah, certainly it remains a challenge in aggregate. And I think that to date, we don't really have a good way around it. But I think when we see results like Dr. Moshfeghi shared, a lot of what we still are surmising from some of these limitations seems consistent with what we might expect. And like anecdotally, what we might experience in clinic as well, right? So in other words, fewer injections correlate to not as good magnitude of vision improvement. So sure, there is some uncertainty on where that that specifics of that magnitude and how we arrive at it, but the conclusions do seem plausible. So I think it's sort of the best we have at this time. Of course, it's nice when we can go hand in hand with something like anatomy, which has more metrics and numbers that hopefully could be more standardized in a sense, but obviously there are limitations there as well. But overall, sometimes with these pretty significant limitations, when you have enough of a volume of data and the conclusions seem appropriate within the context, I think we have something to go by there.
Yeah. Mike, how about you? Because I know this is a issue for Truckee, especially with attrition, right? Because as you go out and analyze data over many months, the number of patients drop off. So your conclusion sometimes might be biased by the number of patients you have. So how do you kind of resolve this when you kind of look at your data?
I mean, I think that's important to understand that obviously people do drop off. But I think the other side of that coin is that what was interesting when you looked at the 6-month data of Truckee, we didn't see vision go down a lot, which I thought was interesting. We were pretty much on par within a letter, which is interesting because we know that if you start treating people over a 6-month period of time with faricimab, as Dr. Ali showed, you start extending people out. So we're able to keep the same slope. You know, it's the concept is you're staying in place while the other group is dropping, because Andrew did a great job showing that over time, these long-term studies show that visual acuity is going to go down as you decrease the frequency of injection. In Truckee, we decreased the frequency of injection, but still kept the vision relatively stable, despite the fact that we really didn't do protocol refractions. Nothing personal. Most of the people are retina specialists and retina specialty groups. They don't even have 4 opters to begin with. So you're definitely not getting the best potential vision, but you're still not getting worse, which is still a win. So if you can keep yourself in the same spot, that's not a bad place to be.
Great. Good. Well, that's great comments. Thank you all for these wonderful talks. And we're going to move on in the essence of time to the next session. Thank you all.
Thank you.
Thanks, Rishi.
Now I'm going to introduce the Genentech Gold sponsor video presentation. Again, we always want to thank our sponsors for making this inaugural Real World Data Summit possible. So I want to thank Genentech for their ability to support this meeting and really the science involved here. That we actually were the initiators of this study, and we've fortunately received very good support from a variety of different sponsors to make this program live this year. And we want to have Genentech lead off with this video presentation.
The power to open their world. Start now with dual pathway Vabysmo.
All right, wonderful. Thank you again to Genentech for sponsoring this wonderful event. So we'll get started with the next session. And I know in the first session, we talked a lot about various data sources and some of the limitations, but in this session, we'll really be focusing on how do we really leverage real world data through the use of more sophisticated methods to really get the most high fidelity insights from some of these data sources. So we'll be starting with my colleague, Brian Vanderbeek from the University of Pennsylvania, and he'll be speaking about picking an index state for your study design. Thanks, Brian.
Thank you, Durga. And thank you again to everyone coming today, as well as the sponsors for sponsoring this great summit. You can see my disclosures here. And today, what we're going to be mostly talking about is kind of the real bare bones of the study. And some of it may be basic, but it's really important to understand these details when evaluating real world data studies. And so everyone's on the same page. We're going to talk about the main designs that you typically see when looking at real world data studies. Those include cohort studies, which is the predominance of what we've already talked about today, case control studies, cross-sectional studies, and then a design that is little less well-known and should probably be utilized a little more often, a self-controlled case series. We're also going to talk about index date. To me, this is the single most important decision that happens when designing any real-world database study. I define it as the relational anchor for which all other dates within the study will be assessed. If you're going to look in a textbook, you're going to find a definition that's more the first date in which all inclusion and exclusion criteria are satisfied. I don't agree with that one fully. I think that's more of a clinical trial definition for an index date. The reason being, until you pick the index date, it's really hard to know whether a criteria becomes an outcome or an exclusion criteria. Sometimes the choice for an index date is very straightforward, and sometimes it's a little harder, as we'll see here. So first, to define a cohort study, this is a study that identifies a subset of a defined population and follows them over time, looking for differences in outcomes. These are generally used to compare exposed patients to unexposed patients, but may also be used to compare multiple exposures to one another. Once you select the exposure status, these tend to be forward-looking. So you're going to look forward in time to see if an outcome occurs.
Now, self-control.
And here we have
a study design that we come across often in ophthalmology. So we're going to spend a second.
Sorry. So here we have the.
Not a study design that we come across.
All right. We're going to skip that slide. That's a diagram basically of the cohort studies. Index date examples for each of those cohort studies. Endophthalmitis rates after intravitreal injection of anti-VEGF agents. So if you're interested in looking at the rates of endophthalmitis, it becomes very obvious when the index date needs to be. It's the date of the injection itself. If you're looking at an adverse event with the use of a specific medication, then it becomes a little trickier. Are you concerned about an immediate adverse event, in which case it becomes the date of the first prescription fill? Or are you concerned with an outcome that only presents after a specific level of exposure? If that's the case, then you want to maybe set the index date later, farther in time after a certain amount of exposure has occurred. We're going to go back one. So this is an example of a study that I tried to emulate. It seems pretty straightforward in that you want to look at the association of statin therapy with vision-threatening diabetic retinopathy. And when you read the methods, it seems very simple. You want to include people that are type 2 diabetic, they're taking statins, and they're over 40 years old. And until you get to the nitty-gritty of deciding when exactly you're going to pick your index date, it becomes very difficult. So essentially, are you saying that it's the same thing for a 65-year-old patient who has been on statins for 15 years and then all of a sudden becomes type 2 diabetic, be included in the study as someone who is 42, has been diabetic for 15 years and then starts statins? There's not necessarily a right answer, but you definitely want to think about the various permutations that are possible so you don't inadvertently induce a bias into the study. So case control studies, this is the next case type of study we're going to go over. This is comparing those with a disease or an outcome to those without a disease or an outcome, and you're going to look for preceding exposures. These are particularly useful when you want to study multiple causes of a single disease or examine many potential risk factors. It's also very helpful when the outcome is rare. And in contrast to the cohort study, these are often backward looking. So you adjust based on the outcome status and then look backwards in time for the exposure.
Now self-control case series.
The next study design is a cross-sectional study. This measures the outcome and the exposure level at the same time. These tend to be more hypothesis generating for use in future studies. The main reason for that is it lacks one of the primary requirements for causal inference, which is the main thing we're trying to do with all of these studies. And that's the inability to determine time course between the outcome and the exposure. This type of study is often confused for a cohort study, particularly when long periods of time are assessed as a single time point. An example of this is, say you wanted to assess the rate of diabetic retinopathy in a certain population. In a real world study, you're probably not going to pick an index date that's a single day, simply because not everyone's going to have an exam or even been evaluated on that day. So you're going to pick a longer time point that better fits your study, whether that's a month or a year. And that can be confusing with the cohort studies, which also combine that time looking over longer periods, such as that. And then we're going to skip that. So the self-controlled case series is the last one I want to talk about today. This is a study design in which individuals act as their own control. Comparisons are made within individuals. Only individuals who have experienced an event are included. Primary comparison is made between time periods within the same individual. The major benefit here is that it reduces time and variant confounding. So if you think about it, if you're just comparing within the same person, whether or not they have hypertension, for example, if hypertension is associated with your outcome, it doesn't change, of course, over a limited period of time if you're looking at a year or even 6 months. It's best, this type of study is best when evaluating an event that occurs in a single time point. This can be a single drug exposure, whether it's a single injection or a surgical procedure of some sort that happens in a very defined set time.
Now, self-controlled case series is not a study design.
All right. We're going to skip those slides there. So in conclusion, choosing the index date is the most important decision to be made in study design. Careful methodologic planning and consideration prior to study the implementation can help to reduce many of the potential pitfalls using real-world data. Thank you. So next, I have the honor of introducing my co-organizer, Durga Borkar. She's going to speak on the use of real-world data to augment clinical trials.
Great. Thank you all for joining us on Saturday morning. So I'll be talking about the use of real world data to really augment clinical trials and not think of them as so mutually exclusive. These are my financial disclosures. I will mention the relevant one is that I'm a medical advisor to Verana Health. So as others have echoed throughout these sessions, I think the highlight of clinical trials is that they're really considered the gold standard of clinical evidence. And real world studies, as many have mentioned, are just not standardized. But I think taking a more balanced approach to this and thinking about both the pros and cons, you can see that, in clinical trials, they do need to be appropriately powered, but overall they have a relatively smaller sample size. They do minimize and aim to bias and aim to decrease heterogeneity. I mean, the goal is really to isolate a treatment effect, but that is when these treatments are used as intended and with regular follow-up. They can sometimes have limited generalizability, particularly based on what the IE criteria may be for a trial. Real-world studies, on the other hand, have a rapidly growing sample size. They often have a very heterogeneous patient population with the disease of interest, and they show the effect of treatment when used on a real-world regimen with often irregular follow-up, which others in the prior session did highlight. They can often be easier to generalize to other populations. So I'm just going to take you through, when we think about clinical trials, sort of pre-trial, clinical trial, and post-approval, how real-world data can really help, and just give an example in each section. So when we think about pre-trial, real-world data can really help us understand unmet need. And we'll see that in some of the geographic atrophy talks we have later this morning. They can also help us understand what the potential market is for a therapy before we even go ahead with clinical development. They can help with clinical trial design. And importantly, they can optimize IE criteria. I think this is particularly relevant now as we think about, for example, how to increase diversity in clinical trials. There was recently an FDA draft guidance about increasing diversity in clinical trial participants. And we know that this is an area for improvement in ophthalmology. There have been various studies looking at clinical trial participation of minority populations and glaucoma studies and diabetic macular edema studies. So the question is really, how can real world data help? Because we know that diversity plans are not one size fits all. You don't expect the same patient population in a geographic atrophy trial that you would expect in an open angle glaucoma study, for example. And so this is an example of a study that I actually collaborated on with Brian Vanderbeek, where we looked at the Optum database to evaluate the impact of hemoglobin A1C cutoffs on diabetic macular edema clinical trial eligibility by race. And our goal here was really to assess the impact of HbA1c thresholds in DME clinical trials by race. We used the Optum database and we defined DME using ICD coding. Our study period was almost 20 years. We identified over 12,000 patients with treatment-naive DME. And when we compared to an A1C criteria of 12 or lower, applying an A1C criteria of 10 or lower, which is often used in clinical trials, sometimes even 8, decreased the proportion of eligible white patients for the study by 12% compared to an 18% decrease for eligible Black patients. And you can see that that is statistically significant. And when we looked at severe NPDR and PDR cohorts, those differences were actually amplified. It's important to keep in mind that we were actually looking specifically at an insured population. So you can imagine that this effect may be even more if we look at an overall group, both insured and uninsured. Important to think about as we design these studies. Once we're at the stage of actually doing a trial, real-world data can help us understand the impact of protocol amendments on eligible populations. It can help us look at site selection and patient recruitment to really complete a trial as quickly as possible. I think that when we look at different studies, there are different tools that you can use. You can certainly use something as simple as slicer dicer in the EHR to identify patients for a trial. Groups like Verana Health leverage data from the IRIS registry to create very streamlined products that are user-friendly, like Verisight, where sponsors and CROs can actually use this tool to understand both site selection and very specific patient recruitment that can help sites identify eligible patients. When we look at a post-approval, this is where we see a lot of the studies that we're presenting today. We can use real-world data to look at post-market surveillance in lieu of a formal phase 4 study. We can use real-world data to understand if there's opportunities for label expansion. Others have mentioned that once drugs are approved, they're not always used in the same patient population that they were used in clinical trials. And then we can also use them to think about validating alternative study designs. So example would be external control arms. So this is an example of a study that we did using the IRIS registry, where we actually used patient-level data to match patients in the IRIS registry to patients in the CAT trial on a patient level. We used various methodologies. Our results were sort of as expected. We saw that patients in these matched real-world arms received significantly fewer injections that had worse visual acuity outcomes. But I think the takeaway here is that this methodology can really be used, in generating synthetic control arms for clinical trials for rare diseases or diseases that currently have no treatment or limited treatment. So I'd urge you, when we think about clinical trials and real-world data, to not think of them as mutually exclusive. I think there's opportunities for real-world data to really augment and enhance what we do with clinical trials. And in fact, they can really streamline the clinical trial process in a lot of ways. Thank you. This is my email here. Would welcome talking with any of you about this topic further. So next, I'll introduce one of my colleagues who works with me at Verana, Zhang Di, and she will be talking about adoption of ocular imaging standards. Thank you, Zhang Di, for joining us.
Thank you, Durga, for the introduction. Hi, everyone. Today is my great pleasure to present adoption of imaging standards. Here are my relevant disclosures. With my presentation, I would like to start with the following take-home messages. First, Imaging data standardization improves quality of care by enabling communication across physicians and institutions. Second, imaging standards holds the key to unlock true power of real-world data in AI and ophthalmology. Third, the DICOM standards is the FDA-recognized imaging standards in ocular imaging and enables big data and AI analytics at scale. Lastly, we should all demand true DICOM from device manufacturers. Imaging tests are an essential part of eye care. Various imaging modalities are used in both optometry and ophthalmology clinical settings. From the perspective of final results presentation, there are two main buckets of imaging data: raw images and imaging reports. Images include things like OCT, OCTA, color fundus, FA, ICGA. Imaging reports includes a broader set of tests and their PDF reports, such as OCT reports, visual field reports. Right now, without universally compliant standards, these imaging data come in all sorts of formats, such as JPEG, BMP, PDF, and proprietary formats that are difficult to organize and index at scale. The lack of imaging standardization today results in challenges for clinicians, patients, and researchers. Unless clinicians share the exact same physical machine, the images are often locked down in different formats, making it very difficult to deliver quality care if patients move, if they're been referred to another provider. Additionally, patients don't have the ability to move or even view their own data. They will likely they will not be able to open a volumetric OCT images themselves if it were to be emailed to them, and it's very difficult for them to acquire these images as well. Lastly, without standardization in images, imaging data cannot be analyzed at scale, let alone to be used for AI development. To truly unleash the power of big data and AI in ophthalmology, it is essential to link imaging data to the rest of clinical data in EHR as well. EHR data is reliant upon clinical examination and documentation. This process could introduce errors, and there might be room for interpretation as well. When you layer an image that's much closer to the actual biology, you get a more complete and comprehensive picture of the patient. Replicate this over time, you can understand the patient journey as measured both by the pathology as well as by accompanying symptoms and other clinical measurements such as visual acuity. However, as of now, it is not really straightforward to link imaging data with EHR data at scale. Without a universal standard, it is very difficult to create a large linked clinical imaging data set. Using the IRIS registry as an example, we went through 3 large steps to incorporate imaging data into the registry. The first step was to acquire imaging data. It was a very labor-intensive process to extract hundreds of terabytes of data from multiple locations, multiple devices, multiple packs. Some are DICOM and some are in proprietary formats. The second step was to convert everything into DICOM. This step was only made possible with close collaboration from device manufacturers directly. Lastly, using metadata presented in the DICOM files and clinical information in EHR data, we conducted patient-level tokenization and linkage, as well as de-identification through the expert determination process. For those who are unfamiliar with DICOM, it stands for Digital Imaging and Communication in Medicine. It is the most widely adopted standard for the communication and management of medical imaging information and related data. Here is an example of what a DICOM file might look like. As you can see, it contains very standardized text to record both metadata associated with their imaging data as well as the actual pixel data. Be aware that sometimes device manufacturers might claim that they are DICOM compliant, but in their actual DICOM files, the pixel data is not presented, or they're not presented in a way that cannot be easily directly read. If you cannot read the pixel data, then it's not really DICOM. There has also already been a lot of work done on DICOM standards in eye care. Here is a list of all DICOM standards from different types of imaging data in eye care. You can see we have specific standards for OCT, OCTA, ophthalmic photos, as well as reports like macular thickness, visual field, biometry, and So there has also been a lot of work led by the AAO, the National Eye Institute, and ARVO to call for true standardization in ophthalmology. Multiple editorials have been published to provide recommendation as well as call for action to widely implement DICOM in ophthalmology imaging. Additionally, the DICOM Working Group 09 has been restarted 2022 September in Chicago. Specifically, the FDA has formally recognized DICOM as a standard for ocular imaging devices. This means that manufacturers can now declare conformity with the DICOM standard in lieu of generating and presenting data for pre-market approval decision-making. Secondly, manufacturers can now add DICOM standard compliance in their labeling, and the compliance must convey accurately the extent to which the standard is being complied with. This documentation for supporting the labeling is also subject to auditing. FDA staff is also approved to participate in this Working Group 09 to improve standards, and FDA is encouraging future AI models to use DICOM compliant imaging technologies as input. To summarize, true standardization in ocular imaging data will unlock the true power of AI and big data in ophthalmology. I would like to end my presentation with a call of action. As a researcher, a physician, it is time to ask for true DICOM from device manufacturers for all you ocular imaging data. Thank you. This is all for my presentation today.
Wonderful. Thank you so much. And I see some great questions coming into the chat. We'll definitely address those during the panel. Looking forward to talking about those. Next, we have Kathy Sun from UCSF Department of Ophthalmology speaking to us about the use of unstructured data in real-world data studies, a primer on NLP. Thank you, Kathy.
Thank you, Durga, and thanks for having me today. So today I'm going to briefly go over how to use unstructured data. We'll talk about why we should use clinical text specifically, how to gain access to clinical text, and some natural language processing methods to process clinical text for research. And then I'll go over a case example from my own research. So unstructured data are data that do not fit into a predefined data model. And about 75% of our electronic health record data are unstructured. Most of that data is clinical text, which I'll focus on today, but images, which we just heard about, and time series data like EKG monitoring data are also considered unstructured. So as physicians, we document a lot of key clinical information in our clinical notes. And by using diagnosis codes alone, which are primarily used in a lot of retrospective studies, we would miss a significant portion of patients with disease. In this study, they looked at a number of diseases, including diabetes, and they found that 40% of type 1 diabetics and 19% of type 2 diabetics were only diagnosed in the primary notes. In ophthalmology, Dr. Josh Stein and his group looked at pseudoexfoliation syndrome, and they found that using exam data and clinical notes, they were able to identify almost twice as many patients than using ICD or ICD-10 codes alone. So gaining access to clinical tests can be a little challenging due to the risk of protected health information. The best way is probably working with your institution's own EHR data. There are a few open access data sets, and the MIMIT-3, which is ICU data, is probably the most commonly used. I'm going to briefly go over natural language processing, which describes a set of techniques used to convert passages of text into interpretable data sets that can be analyzed by statistical or machine learning models. And so these are a few different techniques that can be used. In my own research, we used open source software that does part of speech tagging, which classifies words and phrases as nouns, verbs, adjectives, etc. Dependency parsing, which looks at the hierarchy or dependency between words in a sentence to try to understand the grammatical structure. Named entity recognition, which looks at a block of text and tries to assign appropriate category labels like disease type. And section detection, which tries to identify parts of a document like the past medical history or the assessment and plan section. So I'm going to go over a case example from my own research which was to design a simple rule-based natural language processing classification algorithm using clinical notes, and to compare that to ICD-9-10 diagnosis codes for diabetic retinopathy. So in this study, we used data from the UCSF de-identified clinical data warehouse, which is structured data or discrete elements. And then we also used de-identified clinical notes. So these notes are machine redacted, which means that using Filter, which is an open source de-identification software, the protected health information was removed. And Filter was software that was developed at UCSF. So we identified patients who had diabetes mellitus, also had diabetic retinopathy, had an eye care visit, had clinical notes. And then we took a random subset of 100 patients for a training set and 206 patients for a test set. So all of the training and test set patients underwent manual chart review by 4 of our chief ophthalmology residents who are now all retina fellows. And this was our gold standard. For our diagnosis codes, we used either ICD-9 or 10, depending on the date of diagnosis. Our notes algorithm pipeline included note extraction, applying these inclusion-exclusion criteria. Then we did cleaning, which involved removing abbreviations, random stray punctuation marks. We focused on the assessment and plan section. We used open source software SciSpacey, which does some NLP techniques. We also used an open source software called Negets, which identifies negations. And then for each note, it would tell us if there was a positive mention of PDR, a positive mention of NPDR, and then also if there was any mention of NPDR severity. So this is an example of what a raw note looks like before pre-processing. And then this shows the named entity recognition. So it accurately identified that there were 4 disease elements in this chunk of text. And then in green, it showed that there was no negation around PDR, so there was positive disease classification. In the interest of time, I'm showing the results for PDR, which showed that the notes algorithm did better across the board compared to ICD-9-10 codes. ICD-10 codes did do better than ICD-9 for identifying PDR. So in conclusion, we talked about unstructured data, which includes text, images, time series data. We should use clinical tests as a lot of key information is there. Working with your institution's own EHR is probably the best way, but there is also a few open access data sets. We talked briefly about NLP methods and a case example that found that the NLP classification algorithm with notes did better than diagnosis codes. Thank you.
Wonderful. Thank you so much, Kathy, for that great talk. Next, we have Erin Lee from the University of Washington, who will be speaking to us about considerations for using real-world images to create AI and machine learning algorithms.
Hello, my name is Erin Lee, and I'm from the University of Washington. I'll be giving this presentation on considerations for real-world images to create AI and ML algorithms. These are my financial disclosures. So there's a natural tension when it comes to training deep learning models, and there's a trade-off that you often have to think about. When you have prospective data, these data sets tend to be cleaner because they are collected under some sort of study protocol. And often there may be even image quality checks where the photographer has to make sure that the images are in focus and have an appropriate signal to noise ratio before they're accepted into the data set. The labels that are attached to these images are often very clean and accurate. And so this leads to a data set that usually has a higher signal to noise ratio. But the problem is that these data sets are often very small. And in the era of deep learning, you need large data sets in order to train these models. So usually people turn to retrospective data sets where there are many, many more images available, but the labels are often messy or what is in machine learning called weak. And that leads to a lower signal to noise ratio, but you're going to hopefully overcome that by having enough images available to you so that you can train a deep learning model. And this is really the sort of the trade-off and the tension that's involved. An interesting byproduct of using real-world images, quote unquote, from retrospective data sets is that they often can lead to more robust models because the models have been trained with the variance of noise that is present in real-world imaging. And so if the model is going to be deployed in real life and is going to be used in everyday clinics, then it's best if those models have been trained with data from everyday clinics. But that said, one of the things that this trade-off often means is that people really don't have a choice in the matter. They go with the data that is available to them. And this kind of gets at this idea of what data sets are ideal for deep learning. And obviously, like we talked about, they need to be large, they need to have diverse pathology, they ideally want to be balanced for sex, race, and ethnicity, and contain images or waveforms. And the reason why I'm talking about this is because I want to highlight an effort that we are leading up called AI Ready, where we are trying to generate a very large, multidimensional, ethically sourced data set for studying type 2 diabetes. This is a very large effort with many PIs spanned across the nation. But what we're trying to do is build a data set that would work very well for understanding type 2 diabetes. And here I'm not talking about diabetic retinopathy, but really about type 2 diabetes as a whole. And what we're trying to understand is sample uniformly along this disease axis. And what we're hoping to do is build a data set where approximately 1,000 people will be white, 1,000 Black, 1,000 Asian American, and 1,000 Hispanic. Within that, 1,000 will be normal, 1,000 will have lifestyle controlled diabetes, 1,000 will have oral medication controlled, and 1,000 will be insulin dependent. And within that, ideally one-to-one balancing of males and females. The kind of data that we're collecting includes a medical history, demographics, blood work and urine, all sorts of surveys, including social determinants of health, a battery of cognitive function testing, 12-lead EKG, different visual function tests, and a whole host of different retinal imaging, including many different forms of color fundus photographs, OCT, OCTA, and FLIO. One of the things that's important to note here is that we're actually capturing these different modalities on different machines, so that hopefully people who use this data set to train deep learning models can overcome the device dependency that exists with models. In addition, we are using a portable handheld non-mydriatic fundus camera as part of this data set as well. We will send people home with a continuous glucose monitoring device and a fitness tracker and a custom-built environmental sensor to measure the quality of their air in their homes and do genetics as well as banking. And we hope to make the data publicly available as much as possible. So we have a biospecimen goal as well, so we are banking a whole bunch of different samples, and really we hope that this data set could be used to accelerate data science in medicine. This is our website, this is our QR code, and if you want to follow along as we release our data set, we hope to release our first data set as early as the spring of next year, and then every year thereafterwards during the lifetime of the project. I just want to end by thanking all the lab members as well as the funding sources that support all this research. Thank you.
Great. Thank you, Aaron, for that talk. So we'll move on next to the panel discussion. And I think there's a lot of great questions. Brian, Zhangdi, and Kathy. Great to see you, and thank you to our West Coast speakers for joining us so early this morning. I think we can start with actually some of the questions in the chat. I think David asked a good question here about, curious how far we think we are from regulatory authorities considering ophthalmic real-world data as supporting material and filings and et cetera, and what would it take for us to get there? So I think we can just go around and I can provide my input at the end too and see whether people have thoughts. I think we've all talked about different methods to increase the fidelity of data, but what else would we need to do? Maybe we can start with Zhangdi.
Yeah, thank you, Durga. I definitely think from my perspective, I think some of the main blocker really is the standardization. I think previous presenter have also mentioned that in clinical trials, you measure visual acuity with ETDRS charts, but in real world, you measure visual acuity using different methods that have available for you. So also similarly, when you're doing image measurements in clinical trials, you use central reading centers to do measurements on the images, but in the real world, you will have different measurement methodologies as well. So I do think the standardization of a lot of those measurement methodology will be a big improvement to further advance this goal.
Great. Brian, what are your thoughts?
Sadly, I agree standardization is going to be a big step towards that. Unfortunately, I do think we are kind of far away from that. We're still trying to get the FDA to understand that visual acuity isn't always the best outcome. Think of our dry AMD studies and getting things approved that don't necessarily affect vision, but just may affect the eye, that we know that if you improve the eye health in one way, it's not necessarily just all about vision. And so I do think we're probably a little bit ways from that, but hopefully getting closer every day.
Great. And Kathy, you talked a lot about how we can kind of tap into unstructured data, which can often help increase the types of conclusions we can make. Do you think that's part of the process as well, as we try to move towards making regulatory grade data a possibility in ophthalmology?
Yeah, I think certainly figuring out how to more easily tap into unstructured data. And I agree with what's been said. I think when we think about real world trials, we have to think of it in a different way than clinical trials, because even the endpoints that we can get from our electronic health record are going to be different than some of the endpoints that we can get from randomized controlled trials. So if we're thinking of getting data from the EHR, whether it be structured or unstructured, I think we're going to have to think about kind of workarounds to visual acuity and other things that may be harder to pull.
Yeah, I think all great points. It's interesting, David, when you asked this question, I was thinking about, Zhangdi gave a talk on adoption of ocular imaging standards. And the interesting thing is we don't even really have standards for EHR data to even think about adopting. So I think a first step is really to create those standards. I think we're a group here of people that are really interested in this, in the audience and speaking today. I think coming together as a community and really thinking about standards, both in terms of the data itself and how it's entered in the EHR, but then also how we interpret it. How do we create, kind of reliable, computable phenotypes of certain disease states? I think those are all sort of initial steps to even get there. So just things for us to think about. I think, as Brian said, there is still a lot of work to be done, and I think creating some standards would be a first step. Zhangdi, there's a question in the chat, I think for you, based on what it's about. Someone anonymously asked, for image standardization and OCT, how do we balance, one, standardizing scan methodology to allow for comparison between devices and sites? And I know that's something that you've thought a lot about, and also just promoting further advancement of OCT technology.
Yeah, I think this is a great question. And this is also presents some unique challenges for AI development. In my prior research studies, we definitely have try to develop methodology processing OCT and OCT imaging data from, for example, Zeiss machines, Heidelberg machines. When you develop an AI model using one type of devices, it cannot be directly applied to another type of devices, unfortunately, because of the nuanced differences in how they choose to acquire their data, process their data. But there have been studies that have been able to train deep learning, machine learning, AI models across different types of devices. So I do think AI could be a potential answer for these essentially different scanning protocols and different scanning depth, potentially different lateral resolution, axial resolution that you see in real world data. I think it's going to be pretty difficult to standardize them, as right now it's difficult to standardize the format of the data. I think the scanning protocol will be the next step if we're able to standardize the format of the data. And I don't think this will be a blocker for further advancement of OCT technology. Right now, if you look at different device manufacturers, everyone's working on high resolution OCT so that you are able to essentially, I think there have been some papers to show that for certain devices, you're able to see like really the separation of RPE and Bruch's membrane in dry AMD patients. So I do believe, even though if we're trying really hard to standardize both scanning protocol, image formats for imaging data, I think innovation in OCT methodology will keep coming, as there's always unmet needs to truly have a deeper understanding of different retinal pathology.
Great, thanks. And Jessica Pan asked in the chat about a type of data that we haven't really talked about much this morning, and she's asking how we can best marry surgical console data from device manufacturers like Alcon to either patient-level data or data contained in the Verana Health database. I think this can help with understanding how factors like operating at physiological IOP during cataract surgery can be associated with post-surgical outcomes. Any of the panelists have thoughts on that? Otherwise, I'm also happy to provide input.
I can provide my perspective maybe to kick it off. So I do think it's very interesting when you think about all the different source of data out there for real world data. For the data we have at Verana Health, it's truly just the overall EHR database from the IRIS registry. Right now, I think one of the very popular methodology of linking different data sources through tokenization. So you can work with different vendors or different companies like DataVent, where you don't have to give up any of your patient information, but you will be able to tokenize on the patient level. So there is methodology to link different data sources once you go through tokenization, because no one really have the full picture of all the different clinical data that a patient will go through with their patient journey. So I do think through de-identification, tokenization, this do allow us to potentially being able to link a lot of different data sources and provide a more comprehensive view of patient journey.
That's a great point. Oh, go ahead, Brian.
No, I agree. I think that's a very interesting source of data that I personally hadn't thought of before. But when you think about it, it could be very rich and very useful. And it would probably take some of the manufacturers of the machines figuring out a way to give us the data that I'm sure is stored in the machine with it. But that would be a very fruitful endeavor.
One of the things that I think about too with this question is is there a way to potentially get some of the surgical device manufacturers to work with EHR companies to potentially have even like a flow sheet? When I look at my operative, procedure, I see things like the operative time and, anesthetics used, and a lot of that is manually entered by the operating team. But is there a way for us to more automate the process of, for example, from a constellation, getting all of the information into an Epic flow sheet, and then that information goes to a database like IRIS and we could use it? So potentially linking at the time of patient contact rather than, maybe downstream, although both are great options, I think.
Or even to take it one step farther, maybe as more intraoperative OCT becomes more widely used across the country, we can start integrating the OCTs obtained off that during surgery along with the surgical machine. I think there's a wealth of data still to be mined. And I think a lot of interesting questions could be answered through that.
Great. Yeah. Kathy, I thought your talk was really interesting. I think NLP is sort of where we have to be headed to get insights on certain disease processes. You talked about neovascular glaucoma. What is the next step in that? Do you think that we'll at one point be sort of patenting certain algorithms to define disease states and then people will be using them? Or how can we take NLP to the next level in ophthalmology?
Yeah, great question. I think with the first study that we did, it was a pretty simple rule-based algorithm, and the benefit of that is being able to try to implement it on the back end of an EHR, because if you have something that's really, time and energy intensive, it may be hard to run. But I think definitely large language models are going to be able to do a lot more in terms of identifying laterality, which we had trouble with, and then also disease severity for MPDR, which I didn't go into in depth in my talk, but I think that's really kind of the next step, because I think rule-based algorithms involve a lot of expert opinion, but machine learning and large language models can do things a lot more automatically, and especially with linkage into Epic or other EHRs, I think that's probably going to be the way of the future.
Awesome. And I'll change course a little bit. Brian, really enjoyed your talk. I think, you talked about choosing an index state. And one of the questions I had, because I think it's really relevant to some of the other studies that were presented in the last section, like for far retina, for example, where we define treatment naive and treatment experienced. Once you choose an index state, what do you think we need to do to choose an appropriate pre-index period to really understand sort of the patient journey and whether we can define someone as treatment experienced or treatment naive? And do you think it varies by disease state at all?
Absolutely. I think that's probably the next most important issue. If you think about a lot of studies and what they're trying to answer is they really want the new patients. And so if you don't have a long enough look back period to decide who is new versus someone who's only coming in periodically, maybe they're poor follow-up, you can really bias the sample that you're actually analyzing. And I think there's good data out there to show that the farther back you go, the better off you are. That being said, there's a big difference between 1 year and 2 years, and that's for most disease states. That's obviously not true for all things. If you're worried about an outcome such as endophthalmitis, it's unlikely someone sits at home with endophthalmitis for many months. So maybe you only need a 4 or 6 month look back period for that. But some of the other disease states, especially ones that can go undiagnosed for a long period of time and may not necessarily be clinically symptomatic, like dry AMD or even non-proliferative diabetic retinopathy, something like that, you really want to be sure that you have a longer look back period to be able to get enough data to be certain that the patient doesn't have the disease already and then mischaracterized as a new patient.
Great. I think those are all useful insights. And I think if we could all agree as a community what we'd be using as a pre-index period, I think it would make it a lot easier to compare between studies, sort of Absolutely. How results, compare to each other. Sure. Great panel discussion. Thank you all for participating. At this point, we'll move on to a few words from our silver sponsor, Regeneron. So grateful for your support of this event. We have Michael Atanasio, Associate Director of Thought Leader Liaisons at Regeneron. Thank you.
Hey everybody, how are you? And thanks for having me. I appreciate it. Let me go to the next slide. I'm not sure why it's not. Oh, okay, perfect. I'm here to speak about the Regeneron Way today, and on this beautiful Saturday, 80 degrees. So again, appreciate all your time. Regeneron is a leading biotech company that invents life-transforming medicines for people with serious diseases. As you guys can see, leading technology in our Bello suite, biospecifics and genetic suite, innovative culture, a driven by discovery, and a broad pipeline with over 35 programs in clinical development. Next slide. For over 35 years, our mission has been to use the power of science to bring new medicines to patients over and over again. And this company was founded in 1988 by Len Schecker and George Yanakopoulos. 35 years ago. Initially focused on neuroscience, but as you guys know, we are involved in ophthalmology and other disease states. Next slide. One of our mission is repeatedly to bring new medicines to patients with serious diseases. And what we do is we lead with science. We then take on big ideas. We make it happen by being flexible with our compliance, being great together with our teamwork and collaboration across the globe. And we do what's right for the patients for safety and quality. Slide. This is one of the most important slides that I think, which really resonates with a lot of retina specialists across the nation, is that we have 12 FDA-approved authorized medicines across the US and the globe. 100% of our products have been invented and developed in-house. 35 programs in clinical development areas across multiple therapeutic areas, over 225 peer-reviewed publications since 2022, 4 consecutive years in Dow Jones Sustainability World Index. We have over 12,000 employees since 1988. We are the #1 ranked Science Top Employee Survey for 6 years in a row. And one of the things that Regeneron focuses on is volunteering, which upcoming this next week, we'll be focusing on a diabetic session at some of our centers across the New York area. And one of the things we're really proud of is our Regeneron Genetics Center, which I will mention on the next slide. So what we do is we collaborate to advance science and medicine by working through our Regeneron Genetics Center. One of the things that I really resonate for me as being an employee of Regeneron, and something that we should all take a look at on our website, is this Regeneron Genetics Center. Through the center, we've had 100 collaborations with 2 foundational collaborations across all disease states. And interesting enough, that's where some of these centers come to build upon our new innovation that comes out for our surgeons and specialists across the nation to use. The RNA therapeutics collaboration through Alnylam Pharmaceuticals is where we develop and commercialize new RNA interface for the range of diseases in the eye, central nervous system, and the liver. And our partners across the globe, Bayer, is one of the things that we do. And just as a word out is that we have 35 product candidates in development currently as of 2023. Slide. And what we're all excited to talk about here is EYLEA HD, which is our newest improved in ophthalmology, or anti-VEGF in ophthalmology. Recently approved FDA approval, having two products in ophthalmology, EYLEA and EYLEA HD. EYLEA HD is the first and only anti-VEGF treatment approved in wet AMD and DME for immediate dosing at Q8 up to Q16 weeks intervals following 3 initial monthly doses. Approved for the treatment of wet AMD, DME, and DR. Recommended dosing, as you guys can see on the slide, is for wet AMD and DME is 8 milligrams administered by intravitreal injection Q4 weeks for the first 3 doses, followed by 8 milligrams via injection Q8 through Q16. And DR has a different indication, as you guys can see. Is Q4 weeks for 3 initial doses, followed by 8 milligrams of via intravitreal injection, Q8 through Q12. Next slide. So some warning and precautions, to think about from all injections, including those that have aflibercept, have been associated with endophthalmitis and retinal detachments. Proper injection technique must always be used when administering EYLEA HD and EYLEA. Patients and caregivers should be instructed to report any signs and symptoms suggestive of endophthalmitis or retinal detachment without delay and should be managed appropriately. Intraocular inflammation has reported the use of EYLEA HD and EYLEA. Acute increases in intraocular pressure have been seen within 60 minutes of the injection, including EYLEA HD and EYLEA. Sustained increases in pressure have been reported after repeated dosing with VEGF inhibitors. IOP pressure and the perfusion of the optic nerve head should be monitored and managed appropriately. Slide. We will talk about ROP as a precaution for EYLEA only. Infants with ROP, reactivation of abnormal angiogenesis and fluorescence may occur following treatment with EYLEA. Infants should be monitored closely after injection with EYLEA until retinal vascularization has completed, until the examiner is assured the reactivation of ROP will not occur. Treatment with EYLEA will necessitate extended periods of ROP monitoring, and additional EYLEA injections, laser treatments may be necessary. There is a potential risk of ATEs following VEGF treatments with EYLEA and EYLEA HD. ATEs are defined as non-fatal stroke, non-fatal myocardial infarction, or vascular death. For EYLEA HD, the incidence of reported, ATEs in the wet AMD PULSAR study from baseline was 0.4% in the combined groups, and compared to 1.5 in patients treated with EYLEA 2 milligram. The incidence of the DME, which is our photon study, from baseline was 3.1% versus EYLEA HD, which was 3.6%. Next slide. All right, guys, we're getting through this. EYLEA is the incidence of reported AETEs and wet AMD studies during the first year with 1.8%. The combined groups of patients treated with EYLEA compared with 1.5 ranibizumab through 96 weeks, and it's up 3.3%. And the EYLEA group compared with 3.2%. The incidence in the DME studies from baseline to week 52 was 3.3%. The combined group of patients treated with EYLEA compared with 2.8 in the control group. From baseline to week 100, the incidence was 6.4% in the control combined group of patients treated with EYLEA compared with 4.2%. There were no reported ATE events in the patients treated with EYLEA in the first 6 months of RVO studies. Adverse reactions, the most common adverse reactions in EYLEA HD is cataract, conjunctival hemorrhage, IOP increase, ocular discomfort, eye pain, vision blurred, vitreous floaters, vitreous attachment, and retinal hemorrhage. Next slide. For EYLEA, serious adverse reactions related to the injection procedure have occurred in 0.1% of the interventional injections, including endophthalmitis and retinal detachment. Yet the most common adverse reactions for EYLEA reported in patients receiving EYLEA were conjunctival hemorrhage, eye pain, cataract, vitreal detachment, vitreal floaters, and IOP pressure. And preterm infants with ROP, which is only indicated for EYLEA, the most common adverse reactions reported with retinal detachment, conjunctival hemorrhage, and increased IOP. Adverse reactions and adult indications for IOP that were observed in clinical studies. Next slide. One thing to mention is EYLEA for You. For those that aren't aware, we do have a wide variety of across the whole US, our reimbursement managers, which helps increase product usage or product support for EYLEA HD patients. EYLEA HD is covered for 100% of Medicare fee-for-service patients, which is around 50% of patients prescribed FDA approval anti-VEGF in the US. Next slide. As I mentioned, EYLEA HD following EYLEA, which is the FDA-approved product initially in our ophthalmology sector. Next slide. Was developed with proprietary trap technology. As we all know, it's approved for the treatment of wet AMD, DME, DR, macular edema following retinal vein occlusion, and ROP. This is approved for one single dose strength, pre-filled syringe for the indication of what I just mentioned. Next slide. This is the #1, EYLEA is the #1 prescribed anti-VEGF across, and when you think about this, for the last 11 years in real-world data, it has over more than 64 million doses administered worldwide since the launch across all indications, and it gains robust vision gains in wet AMD, DME, retinal vein occlusion, and anatomic outcomes across all other indications. Next slide. One thing to end here is thinking about at Regeneron, we never stop asking why. With our proven innovations since 1988, with 12 FDA-approved medicines or authorized medicines, we're not stopping here. We have a broad pipeline and 12 late-stage programs. We're focused on ophthalmology and to all our retina specialists across the US and the globe. One thing what I mentioned is our genetic suite, right, is to keep that groundbreaking technology thinking ahead. And we have our fearless culture as being a top biopharma employer, and we're dedicated to you. So thanks for your time.
All right, great. Thank you very much. So thank you, Michael, for that talk. And again, for Regeneron for sponsoring this first inaugural Real World Data Ophthalmology Summit. Really appreciate the support that we received from Regeneron for making this program live this year. Michael, how do you say your last name? Apologies.
Bagu. It's a mouthful.
Michael Bagu, thank you very much for joining us. I know we were in your last session. We had some connection issues. Really appreciate you joining because we really want to hear from you on, Doctor, about the considerations for using real-world visual acuity in clinical trial outcomes. We had a little bit of this discussion earlier in some of our panels, so we would love to hear from you about your thoughts on this topic. Thank you.
And Thank you so much for having me. Alrighty, so go ahead and get started again. I'll just briefly introduce myself. I'm Mike Mbagwu. I am a adjunct faculty at Stanford as well as senior medical director at Verona Health, and I'll be presenting on considerations using RWE with visual acuity. So visual acuity, we all know, or a lot of us know what this is. It's really that objective measure, seeing how well the eye works, but it's seeing how you can distinguish a shape or details at a certain distance. And we have our acronyms below that many of us are familiar with: OD, OS, or OU, referring to right, left, and both eyes. Visual acuity, of course, is always taken one eye at a time for the most part. So I want to spend some time to level set on how does VA appear in EHR data, how to use it, etc. So here we see a familiar screen for a lot of us, especially docs, which is visual acuity. This is EPIC, written here with some information, distance. So we know that this is taken at a distance, right and left eye, and CC, which they specify here what version of correction is used. But perhaps one of the most important things to remember is this is how visual acuity appears on the EHR front end. So most of us who are clinicians on this call will know exactly how that is, but really back-end data is what matters most, at least as it pertains to manipulatable data that we can drive conclusions or do studies on. Now, here it's mostly in the form of strings. So you see a field name that hopefully informs what's the data is going to be, and then the value itself. And I've written there in quotes. So this will bring me to really the first point here, which is remembering to process all of your data as text in that numeric value. In doing so, or if you don't, then it will be understood as 20 divided by 50 as opposed to the string that we want now. So how is visual acuity written in EHR notes? Here's another version of an EHR. So this is a different vendor. If you were to click that one of those levels or one of those buttons, you would get a radio button that looks like this. So 20-blank, and then you fill that in. Why am I making the point here? It's because here the values within the fields would say 40 instead of 20 over something, because really the 20 is implied. And that's always something to remember, that really when you're evaluating the data, consider how it might look on the front end. So that way your back end interpretations might make sense. So again, here, the 20 would be implied if you're looking at the front end. So all of your data correctly will be missing that when you go to process it. So another thing that comes up a lot with visual acuity is this idea of BCVA. It's really the verbiage we're used to for clinical trials. And I saw somebody from Regeneron and Leah just before me. So I know that their clinical trials mentioned that, and all of them do. For real world data, it's very, very, very important to remember, for the most part, visual acuity is often written corrected, but not necessarily after refraction. And to call something BCVA, it required visual acuity to have been refracted or obtained in the context of refraction. And again, BCVA is not necessarily visual acuity just when wearing glasses or correction. So that's something, again, to remember as you use data from the back end. So here's another larger screen with different visual acuities and different values written here. And really understanding, taking all the ones that exist and processing it and getting really that best one to represent each eye at one specific visit is really what you need. Making sure you're always using the appropriate terminology. So how do you use visual acuity data? Logmar, again, something a lot of us have seen, and really we can convert all of our visual acuity data to something like Logmar. But again, it's anytime you do some sort of transformation, making sure you very clearly list it out. Here, I'm just showing a Logmar chart for those who may have not seen this before. Here's a conversion table. These are all very standard. But again, the most important thing by far and away is making sure that you use standard tables. So here I just kind of illustrate my point earlier, which again, converted visual acuity to a logmar is not the same as visual acuity taken on those specific charts. We'll go over here too. When you use visual acuity, making sure you're always using that proper terminology. So the point I'm trying to make here is if it wasn't taken refracted, and if the visual acuity wasn't obtained on a logmar chart such as ETDRS, if you do apply those conversions, making sure that you always really explain the data that you have, calculated logmar, estimated logmar, something of that nature really shows, I think really just highlights the process you used and not misrepresenting your visual acuity data. Okay, and I'll breeze through these just so you know, there are different units that visual acuity can be written in, Jaeger units, etc. So making sure you understand, is this VA data fit for your purpose? If it's a study that requires distance data, you wouldn't want to use Jaeger units. And lastly, special cases. This is just something to always remember. We do want to obtain visual acuity for, hand motion, count fingers, light perception, to make sure we're representing all populations with visual acuity data. And while there are conversions exist, or equivalencies that exist, making sure that you highlight that if you're including those in one of your research studies. So again, here's my conclusion. The biggest thing to remember with visual acuity data is it's very foundational to what we do in ophthalmology, understanding terminology, using it correctly, and always understanding the context of the data you're trying to process, everything from the field name all the way to how you report it. Thank you.
Thank you, Doctor. That's really nice for you to give that talk, and really appreciate your participation. And I'm sure there'll be questions that come up in the panel, and happy to have you answer them. So let's go on to our next section, which is retinovascular disease, and we'll have our first talk come up. This is going to be by Dr. Michael Ip, and Michael will focus on treatment patterns and 5-year visual acuity outcomes in patients with RVO, analysis of real-world database from the U.S.
Hello, everybody. It's a real pleasure to be with you here virtually at the Real World Data Ophthalmology Summit. And the topic of my talk is going to be treatment patterns and outcomes with anti-VEGF therapy for BRVO and CRVO, and analysis of the Vestrum database. My co-authors can be seen listed here on this slide. My financial disclosures can be seen on this slide. The study objectives were to evaluate treatment patterns as well as visual acuity outcomes over a 5-year period in patients who had macular edema secondary to branch retinal vein occlusion and central retinal vein occlusion, who were treated in routine clinical practice in the United States. This was a retrospective and observational study of the Vestrum Health database. The time period was 2014 to 2021. Study eyes had macular edema secondary to BRVO or CRVO that were identified using ICD-9 and ICD-10 CMN codes. Eyes were followed up to as long as 60 months since the index intravitreal anti-VEGF treatment was provided. The patient eligibility criteria can be seen here. Highlights are that the patients had to have received 1 or more anti-VEGF injections on or after the diagnosis of macular edema. The eyes were treatment naive for anti-VEGF therapy, intravitreal steroids, and laser therapy. Eyes had to have had a minimum of 3 months follow-up. This slide shows the differences between the BRVO and the CRVO cohorts. They are relatively similar, with the exception of the time from index diagnosis to index treatment being longer in the branch retinal vein occlusion group at 31.6 days compared with 19.5 in the CRVO group, and the visual acuity at index treatment was higher at 53.4 for the BRVO group than compared with 36.5. There were a large number of eyes analyzed in this database analysis. With at least 3 months follow-up, there were over 22,000 eyes in the BRVO group and over 18,000 eyes in the CRVO group. There was significant attrition starting immediately at the 6-month follow-up, going all the way out to the 60-month plus cohort Yet there were a large number of eyes that were remaining. There were over 2,100 eyes in the 60-month BRVO cohort and over 1,700 eyes in the CRVO 60-month cohort. This is the first of the results slide, and it shows that grid pattern laser and intravitreal steroid treatment were uncommon in the first year. However, grid laser photocoagulation and intravitreal steroid treatment increased over time. Notably, we see that almost a quarter of the eyes in the BRVO cohort received grid pattern laser photocoagulation in the 5-year cohort. Also notable is that over 10% of the eyes in both the BRVO and the CRVO cohort were noted to receive intravitreal steroid treatment beginning at year 3. The mean number of anti-VEGF injections concomitantly decreased over time. You can see that there's a decrease from a mean of about 7 injections in the year 1 cohort, which reduces out to 3.7 injections in the 5-year BRVO cohort and 3.9 injections in the CRVO 5-year cohort. This reduction in the mean number of injections begins as early as in the first year. If you break down the first year into quarters, you can see that the maximum number of injections was 2.7 in both the BRVO and CRVO cohorts in the first quarter, which reduces down to about 1.3 mean injections in both of the cohorts in the fourth quarter of the first year. Concomitantly, the magnitude of the mean visual acuity gained from baseline decreased over this 5-year period of time, from a little under an 11 visual acuity letter gain in the 3-month cohort, reducing out to 8.2 in the BRVO cohort at the 60-month follow-up, and 5.3 in the CRVO cohort with the 60-month cohort group. Another way to look at this is the visual acuity gains declined from month 3 in both the BRVO and the CRVO cohort compared with what you see in the first year. This slide shows that in the BRVO cohort, those eyes that had the lowest injection number by tertile over 60 months tended to have worse visual acuity outcomes compared with the eyes that had higher injection numbers. So you can see that the eyes in the 60-month cohort that had greater than 29 injections, as you can see here in the blue line, have better visual acuity results compared with the eyes that had the lowest number of injections, less than 15, as exemplified by the orange line on this graph. Similar results were seen in the CRVO group. You can see here that the eyes that are denoted in the blue with over 31 injections in the CRVO group in the 60-month cohort had the best visual acuity outcomes compared with those eyes that had the lowest tertile of injections of less than 18, as you can see here in the orange line at the bottom of this slide. So to conclude, BRVO and CRVO with macular edema appear to be chronic and long-lasting conditions, with many patients requiring long-term treatment and or monitoring out to at least 3 to 5 years. Treatments such as grid pattern laser photocoagulation and intravitreal steroids are uncommonly used as initial therapy when used as adjunctive therapies for anti-VEGF therapy. However, this use of grid pattern laser and intravitreal steroids do increase over time. Visual acuity gains in clinical practice are lower than those reported in the registrational clinical trials, possibly due to undertreatment. We see this with the mean number of injections decreasing both within and after the first year of initiation of therapy. We also see that eyes with the lowest injection numbers tend to have the worst long-term visual acuity outcomes. All of these data suggest that current therapies are effective, but might be inadequate with respect to the long-term durability that's needed in a real-world environment. Thank you for your attention, and thank you for having me in this Real-World Data Ophthalmology Summit.
Thank you, Michael. And so we're going to obviously come back to you and discuss some of these in a panel discussion, but let's continue. And Dr. Thomas Chula will be discussing visual acuity outcomes and anti-VEGF therapy intensity and DME, real-world analysis of eyes in a study. Thank you very much.
Today I'm going to discuss visual acuity outcomes and anti-VEGF intensity in a real-world analysis of nearly 30,000 eyes. My disclosures are shown on this slide, none of which are relevant to this presentation. I have previously presented and published on clinical practice outcomes in neovascular AMD, DME, and RVO-associated macular edema. In one of these studies, we assess outcomes with anti-VEGF therapy and diabetic macular edema. In the 12-month cohort, there were nearly 6,000 eyes. They received a mean of 7.8 injections and gained a mean of 5.2 letters. Mean change in vision over time is shown for each cohort. Each group gained approximately 3 to 6 letters. In these studies, we use the Vestrum Health Retina database, with which many of you are familiar. In brief, this database aggregates de-identified data from hundreds of U.S. retina specialists and includes data from 2.3 million patients. The formula shown here was used to convert Snellen visual acuity into an ETDRS approximation, but this obviously can't compare to a standardized ETDRS protocol refraction. In the current study, we sought to answer the question, how does treatment intensity affect outcomes at 12 months? We increased the sample size and modified the eligibility criteria. Specifically, there was no requirement for induction with 3 or more monthly injections in the first 4 months. In terms of demographics, there were nearly 30,000 eyes. Approximately half were male and half were female. Approximately half of the patients received bevacizumab as initial therapy, and the other half was split between aflibercept and ranibizumab. How were injections per year per eye distributed? The number of injections per patient in the first year ranged from 1 to 13. The median number of injections per patient eye was 6. The distribution of injections per patient eye was skewed towards the lower range. Approximately 50% of eyes received 6 or fewer injections, and approximately 20% of eyes received 10 to 13 injections, representing monthly treatment over this 1-year time period. Baseline visual acuity did not correlate to treatment intensity. In other words, those who received few or many injections were not necessarily better or worse at baseline. With regard to top-line results, at 12 months, the mean number of injections was 6.4, and the mean change in visual acuity was 4.2 letters. There were no meaningful differences in outcomes based on initial anti-VEGF agent. Real-world DME eyes with worse baseline visual acuity gained more vision than those with better baseline visual acuity. The eyes were stratified by baseline visual acuity in one analysis. They received a similar number of injections. Those with the best visual acuity tended to lose vision and vice versa, demonstrating a ceiling effect. The change in visual acuity versus injections over 12 months is shown. This shows 2 distinct themes. First, eyes which receive fewer than 5 injections in 1 year improve minimally, gaining approximately 2 letters at 1 year. Second, there appears to be a linear relationship between the mean number of injections and the mean letters improved over 1 year. Eyes with good baseline visual acuity, 20/40 or better, generally lost vision unless they received intense therapy. Those with moderately severe baseline impairment, 20/70 to 2200, who received 10 or more injections in 1 year improved by a mean of 10.3 letters, which is reassuring. Colleagues tell me that their results are better, or that other studies show better results. However, it's simply not true. The results are similar to prior smaller studies shown here. In summary, real-world DME patient eyes experience only a modest gain in visual acuity at 1 year. Better baseline visual acuity increases the risk of vision loss. Injection frequency plays a large role in visual acuity outcomes. Real-world DME patient eyes receive approximately 6 versus 9 injections across well-known randomized controlled trials. Real-world outcomes are worse than in randomized controlled trials by approximately 1 line of vision overall, and 2 lines of vision for those with good baseline visual acuity. This paper has been published in the British Journal of Ophthalmology and is freely downloadable. Thank you very much for your interest.
Thank you, Dr. Chula. And I'd like to introduce our next speaker, Dr. Blanche Kuo. Hi, Blanche. Nice to see you again. On the effects of loading doses on real-world outcomes for diabetic macular edema treatment.
Hi, thank you for the introduction. So I'll be discussing the effect of loading doses on real-world diabetic macular edema treatment outcomes. Below are my co-authors, and I have no disclosures to report. So intravitreal anti-VEGF therapy is considered the first-line treatment for diabetic macular edema. And as we just heard, Chula and colleagues examined the real-world outcomes with anti-VEGF injections and said that outcomes consistently fell short of those seen in clinical trials, likely due to suboptimal dosing frequency. So Menon and colleagues showed that in neovascular AMD, loading doses correlated with better visual acuity outcomes, which has led to the idea that loading doses are necessary when initiating anti-VEGF therapy. Real-world studies using large electronic databases, such as Cantrell and colleagues' study using the IRIS registry, have been valuable in understanding treatment patterns in patients with diabetic macular edema. However, to date, there's no comparable real-world data study that examines the efficacy of loading doses for patients with diabetic macular edema. As such, the purpose of our study is to define and compare the patient characteristics, treatment patterns, and clinical outcomes of treatment-naive eyes with diabetic macular edema who do and do not receive loading doses at anti-VEGF initiation. Utilizing the IRIS registry, treatment-naive eyes with diabetic macular edema were queried, with the shown inclusion and exclusion criteria applied, which resulted in a total of 77,000 eyes in the loading dose cohort and 139,000 eyes in the non-loading dose cohort. We define loading dose cohort as defined as eyes receiving at least 3 injections within 100 days of treatment initiation, and non-loading dose at those who did not meet the loading dose definition. We first looked at injection volumes and injection intervals. The blue bars here represent loading dose cohort, and the red bars represent the non-loading dose cohort. When looking at the injection volumes, we saw that even after year 1, in each subsequent years, eyes receiving loading doses received more injection than the non-loading dose cohort. Similarly, in eyes that receive loading doses, injections were obtained more frequently with shorter injection intervals year over year. We then looked at eyes with significant visual acuity improvements as those who had achieved greater than or equal to 15 letters both at any point during the study and at the end of the study. We found that eyes receiving loading doses more commonly improved greater than 15 letters than those that did not receive loading doses. Additionally, in both cohorts, visual acuity improvement was most prevalent amongst eyes that initiated anti-VEGF treatment with worse than 20/40 baseline vision. We also examined treatment switch, looking at eyes who had received at least 4 injections, and saw that eyes without loading doses were more likely to switch treatment agents than those who did. Among eyes who switched agents, it was more common to switch away from Avastin to other FDA-approved agents for both cohorts. We then examined eyes discontinuing and reinitiating treatment, and these were both less common in eyes receiving loading doses. Less than half of eyes who had received loading doses discontinued treatment, compared to nearly 2/3 of eyes in the non-loading dose cohort. We saw a similar trend in eyes who reinitiated treatment, with 17% in the loading dose cohort and 25% in the non-loading dose cohort. Finally, we performed adjusted analyses controlling for baseline characteristics and found that having Medicaid insurance or starting treatment with Avastin was significantly associated with vision loss throughout study follow-up. Generalized estimated equations modeling showed that being of white race was associated with increased likelihood of receiving loading doses. Similarly, having commercial insurance or having baseline VA between 2025 and 2200 were more likely to receive loading doses. In a multivariate analysis, the strongest predictor of treatment discontinuation was starting with Avastin as the anti-VEGF agent of choice. Receiving multiple agents throughout follow-up was also a strong predictor of treatment discontinuation. In conclusion, this was a large retrospective study using the IRIS registry, including over 200,000 eyes who are treatment naive and had diabetic macular edema, who initiated anti-VEGF treatment. Several socio-demographic factors were associated with increased likelihood of receiving loading doses of anti-VEGF injections. Treatment and clinical outcomes were different according to whether or not loading doses were received. Patients who received loading doses were less likely to switch or discontinue treatment than those who did not, and were more likely to achieve considerable VA improvements as measured by patients achieving greater than 15 letters of VA improvement. These findings will be important for us to keep in mind in routine clinical practice. Thanks.
Thank you, Blanche. Really appreciate that discussion, and we'll get back to some question and answers in the discussion portion for today. So my next speaker is Dr. Jorge Fortun. He's going to talk about real-world outcomes for sustained steroids and diabetic macular edema. Dr. Fortun?
Thanks, Rishi. As you mentioned, I'll be talking about real-world outcomes of sustained-release intravitreal steroids, mainly the two approved devices, which are the dexamethasone and the fluocinolone implant for the treatment of diabetic macular edema. As we can see, based on clinical trial data, Protocol T using first-generation anti-VEGF agents, a significant portion, nearly a third of patients, remain and have persistent DME out to 6 months. Protocol I sub-analysis further showed that there is over 50% of patients that don't have an early and consistent response to anti-VEGF in DME after 4 anti-VEGF injections. Further analysis, the early analysis of Protocol I showed that patients will usually attain their greatest visual gain after 3 injections and will remain in these so-called swim lanes for the remainder of study treatment. And the reason for this incomplete response with VEGF may have to do with the heterogeneous pathophysiology of DME, as we've come to understand it, where it is not only a VEGF-mediated process, but where all these other cytokines, inflammatory cytokines, play a role of inflammation, leading to not only edema and neovascularization directly and through upregulation of VEGF, but also through neurodegeneration. The dexamethasone implant was the first sustained release implant approved for the treatment of DME. The MEET study design is worth mentioning because it was the registration trial that looked at the efficacy of this device. And of note, this treatment was given approximately every 6 months. So please take that into account when you look at the data. But overall, it showed improvement in both vision and OCT results post-cataract formation. You can see here a characteristic rise in IOP at approximately 6 weeks, which is how most of us look for IOP rise with the dexamethasone implant in clinical practice. What about post-approval real-world studies? In this meta-analysis of 30 studies, it was found that the DEX implant resulted in a significantly greater visual acuity improvement and OCT detergescence than anti-VEGF therapy in resistant DME patients. Additionally, the DEX implant was not inferior to anti-VEGF therapy in patients with non-resistant DME. And so the goal really should be to break out of those swim lanes that we're seeing in the early sub-analysis. And it shows that clearly switching patients with resistant DME is effective, but that the timing of the switch may be as important or partly important as switching. And so switching to steroids at 3 months led to an 8.9 letter gain in this real-world study, whereas switching to steroids at 1 year led to lesser degree of improvement. What about combination therapy? Several small trials post-approval have looked at this, but the largest trial to date has been the Protocol U trial, and it found no difference in visual acuity. However, it is important to note that this trial was not powered to evaluate differences between phakic and pseudophakic, and so it did show perhaps an anatomic improvement in combination therapy with a greater reduction in the combination group with receiving both dexamethasone and ranibizumab, as well as a greater proportion of patients in the combination group being 3-line gainers. The fluocinolone acetonide intravitreal implant, or Iluvien, is seen here. And for the interest of time, we will briefly mention the FAME study, which was the registration trial, and to show that the primary outcome was met with patients achieving greater than 3 lines from baseline and receiving minimal supplemental therapy, again, with improved central mean point retinal thickness. Of note, one of the things that was found in the real world studies, which we'll review shortly, is that with steroids, having a steroid challenge can safely predict steroid IOP response. First real world trial that we'll talk about is the user study, looking at treatment burden pre and post-diluvian administration, as well as visual acuity and intraocular pressure signals post-injection with fluocinolone. As you can see here, which echoes nicely what Dr. Chula mentioned, the amount of undertreatment that occurred pre-administration of the drug, where you can see here that patients in general were treated quite infrequently leading up to enrollment. And you can see here a maintenance of visual acuity in the better groups and actually improvement in visual acuity in the worse seeing eyes with a dramatic decrease in treatment frequency. And again, you can see here one treatment every 3.5 months leading into it, and then actually improvement in the central retinal thickness with one treatment approximately every 1.5 years following administration of the fluocinolone implant. IOP remained stable over time. More recently, the Paladin 3-year prospective phase 4 study was published, and you can see here again improvement in or decrease in visual acuity with real-world treatment with anti-VEGF therapies, again accounting for because of decreased or infrequent treatment, and post injection with fluocinolone implant, a gain of about 4.5 letters in all patients with decreased treatment frequency. You can see here again that mean IOP remained stable, and of note, a steroid challenge led to significant decrease in IOP-related events, with only about 30% of patients requiring any IOP-lowering surgery, and only 2.5% of patients requiring IOP surgery due to steroid-induced glaucoma. So in conclusion, anti-VEGF has revolutionized the way that we treat DME, but may not be a complete therapeutic picture. DME pathogenesis is certainly involves inflammation and is heterogeneous, and so sustained release intravitreal steroids have shown in real world studies to represent promise in refractory cases, as well as reducing treatment burden.
Thank you. Thank you, Dr. Fortune. So we're going to get to some questions for you in the panel. Really appreciate that. The next speaker is Dr. Nitish Mehta from New York Langone. Thank you, Dr. Mehta, for joining us today. He's going to talk about the impact of initial monthly doses on aflibercept on visual acuity outcomes in eyes with DME in routine clinical practice in the U.S.
All right, thank you very much for having me. This is a very exciting meeting. So I'll be talking on the impact of these monthly doses of aflibercept on visual outcome in eyes with DME in routine clinical practice. So similar to some of the other work we've done, we've been seeing here today. I'm trying to advance, okay. These are the disclosures. So we know that in the phase 3 Vivid and Vista DME trials, there were 5 initial monthly loading doses that were given, followed by Q4 or Q8 weight dosing. And we know that in routine clinical practice, this may not actually be the case. And a few real-world studies have already shown that, with perhaps of up to 88% of eyes deviating from the clinical trial protocol. And there's also some suggestion that those eyes may have poorer visual outcome. And so we aimed to use a large database to assess the factors associated with the initial treatment frequency and their impact at 12 months in eyes with DME. And as we've heard, in the Vestrum database, there's around 300,000 eyes with DME, and we included eyes that had DME diagnosed between 2015 and 2021 that received aflibercept as first-line therapy without switching the initial loading phase, and that had a greater than 18-month treatment history in the database, and that found around 23,000 eyes. The outcome measures were changes in VA and CST, the proportion of patients with our common vision gain loss categories, and we looked for baseline factors associating with receiving different numbers of these initial doses. So to facilitate the analysis, the cohort was identified, was then divided into 3 subgroups. So those that had received 1 to 2 injections, 3 injections, or 4 or more injections. So looking at the baseline characteristics, we can set around 8,000 patients received 1, 2, 7,000 received 3, and 9,000 received 4 or more. Breaking down by age and sex, pretty similar, but we can see here that the proportion of patients with the specific forms of DR were different. So in those that only received 1 to 2 injections, a greater proportion of those patients had PDR, and a greater proportion of eyes in the higher treatment arms had moderate and severe PDR. Also interesting was that the patients in the lower injection cohorts, they often had a longer time from diagnosis to treatment. Over the 12-month course, they had fewer visits, more breaks in treatments, and more losses to follow-up. So this particular cohort seemed to have more difficulty potentially adhering to treatment schedules. But on the other hand, vision tended to be better at baseline in the patients in the lower injection cohort. And conversely, the CST tend to be thicker in the patients that were being treated with 4 or more, suggesting that we may have been a little bit more pushier on treatment schedules in eyes with poor vision and worse CST. So summarized here are the factors that were shown to be associated with receiving that higher initial loading monthly cohort. So those patients that were younger than 65 years of age and female gender were actually less likely to receive 4 or more injections in the first 5 months. And patients with type 2 diabetes and vision worse than 20/40 were more likely. Regarding anatomic factors, we can see here that patients with thicker CSTs were more likely to receive that group 3 treatment. If you were diagnosed with DR and DME at the same visit, you were more likely to receive higher levels of dosing in the initial monthly loading cohort, and those with severe NPDR as well when it comes to the DR. So here's an important slide as well, showing you the vision and anatomic outcomes. So at, say, month 6, when you've done your initial loading dose period, those eyes that have received more tend to have better vision gains, better CST reduction, and this held at month 12. The proportion of patients that lost vision in each cohort, 5, 10, and 15 letters lost, were less when they had received more initial treatment. On the converse, in the proportion of gain, 5, 10, and 15 letter gain, the higher proportion of those patients were the ones that received more initial loading doses. On the baseline factors, we can see that there's more odds of gaining 15 letters when you had poor initial vision. CST did not seem to be as much of an impact in terms of the odds of gaining. And finally, there was again a greater odds of gaining 15 letters from baseline if you were aggressively treated in the initial monthly loading dose period. So the key features of the study are shown here. You can see that eyes with poor vision and higher CST were more likely to receive a greater number of injections in the initial monthly loading dose period. There were trends of increased visual and anatomic outcomes. There was a greater proportion of patients that lost fewer letters when receiving more initial monthly dosing. However, visit frequency and DR stage played a role, suggesting that there may be other factors influencing why certain patients were receiving different initial monthly dosing period. Thank you very much.
Great, thank you, Nitish. I really appreciate that talk. And so we have a time for all of our individuals to come back, and thank you again for all of your excellent speeches on this topic. Let's focus for a moment on the loading dose question, because I think both of you sort of looked at this a little bit differently. So Dr. Mehta and Dr. Kuo, you both had loading doses as part of it, both in DME and RVO. Talk a little bit about the definitions of loading, because I think that's an important one, and what is truly what you found in the study as far as that interval that you quantified, because I think that we don't inherently know based upon the chart who's loading or who's not loading. And so there were definitions you had to apply. How relevant do you think those definitions truly are?
Well, for our study, we defined the loading doses as having at least 3 injections in the first 100 days of treatment initiation, which is kind of based on the randomized clinical trials that established the efficacy of anti-VEGF injections for DME in the first place. So I think if you average those 3 injections, at least in the first 100 days, which is like 3 months, a little bit more, give or take, it's kind of consistent based on the clinical trials. And it's difficult to say if all of them are 1 monthly doses, or if they're more frequent or less frequent than that. But with a large data set, I think this is an appropriate definition to kind of consistently look at who is receiving loading doses and who isn't, but obviously not accurate to the pinpoint.
Great. Dr. Mehta?
Yeah, I definitely agree. I mean, you're going to have to use some gold standard in defining this. And basically, the clinical registration trials are the ones that are going to be the clearest ones to use as your definition. I mean, perhaps if we look a little bit more granular and, you look at the chart and the natural language processing and see if someone's making an effort to truly do loading dose, or whether they're doing a treat and extend and it just happens to also fall into that as well. So I think we have to sort of understand what the thought process is for the treatment provider.
Yeah, I agree. Dr. Bagu, if you could comment a little bit on visual acuity. I think your presentation really did a great job of summarizing the various acuity methods, and it's plagues real-world studies. So you mentioned a couple different modalities. We use usually something like we term BVA, best vision any method. Is that a reasonable approach, or what are your kind of thoughts on this and how to resolve that?
Yeah, I'd say first and foremost, the genuine recognition of what our VA data is and our best efforts to represent that data is all we need. So I heard you said BVA, that is, your messaging to your writer or your readership that indeed that's what your visual acuity is. I like the term best documented visual acuity, just because I think it drives home what it is we're actually looking at. So that's kind of my bias or my recommendation. But even still, visual acuity is and always will come from disparate sources from real world data. And it's just our ability to untangle that, put them into something standardized, and message exactly what we're giving out. That's the important thing.
Yeah. And you spoke a little bit about the ETDRS and Snellen acuity conversions. Are we close? What is the threshold? I've seen some studies that show at bad vision levels, it differs in good vision levels. Kind of give us some summaries and thoughts on that.
Absolutely. There are differing opinions. For the most part, I've actually seen there's a recent study that showed Snellen visual acuity is a little worse than ETDRS. And again, it's hard when you're not taking things in the exact standardized way. Having said that, there are conversions. They are generally, acceptable. They're generally best practices. Above all, you want to minimize conversions. That is to say, going right from Snellen to Logmar, not, Logmar to Jaeger to Snellen, then back to something else. So just keeping consistent, minimizing transformations is probably best practices.
Yeah, great. Dr. Fortune, you focused on steroids and its outcomes as far as being able to be a second-line therapy potentially to anti-VEGF, but when would you ever consider it, based upon some of the data you presented today, first-line therapy potentially for some patients?
Well, I think when you look at that meta-analysis that looked at some of these studies that used it as first-line therapy, it shows that really, at least in all comers, it's not inferior. I think the holy grail is to try to have imaging biomarkers, perhaps, that could point to patients that may respond better from steroids. We certainly know that there's a subset of patients, even with intensive treatment, that are incomplete or non-responders to anti-VEGF. And then you certainly have to take into consideration risk factors of complications, right? So, obviously a phakic patient with glaucoma issues would not be your ideal choice for first-line therapy. Hopefully, we have a prospective study coming up with the fluocinolone implant, looking at treatment naive patients that may shed light on if there's any benefit, for early first-line therapy with sustained release steroids.
And I'll ask you all maybe this question. these populations you're talking about, DME and RVO, are different than our neovascular AMD populations. In real world analyses, sort of what have you found are some of the limitations it would relate to this population in particular? Maybe Dr. Maida, you want to start off?
Yeah, I think that was one of the key things that jumped out to me when looking at this data, is that patients with PDR were likely getting less injections and had more loss to follow-up. And so there probably are other social determinants of health, or ability to get to clinics. I think that we can use this to actually start to look at why are patients having a hard time coming in. Are there other factors that we can look at? Because that's going to totally change the way that we're assessing our desires. Are we looking at these patients and saying that they need less injections, or do they need injections and they're having a hard time getting it done? So it helps us open up the door to looking at this in a different way.
Any other thoughts or comments? Blanche, Dr. Kuo, you did the study. There are some attrition issues with these studies, as you know. What sort of things would you sort of pull out from that sort of analysis?
Yeah, so I think if we look at the cohort attrition year over year, there's a substantial drop in our study populations after like year 4, 5, 6. So things that are hard to control for in these large data studies are kind of the external factors that affect whether these patients are able to continue seeing their providers. And specifically in the DME populations, these diabetic patients usually have a lot of other microvascular complications, whether that be like diabetic kidney disease. And I think these are things that might not be accounted for or documented in the EMR if the patient is receiving treatment outside of whatever provider their ophthalmologist, whatever institution their ophthalmologist is at. And that's definitely a limitation of these studies, really seeing the whole patient outside of just the ophthalmic care.
Rishi, I'll make a comment about real world studies for steroids. And I think one of the biggest problems, as you mentioned, is that most of us are using these as second line agents. And the problem with that is that it makes very hard to interpret the data after the switch, because clearly these patients have had chronic disease that has been undertreated on the front end, but then also been sitting around for a while, which, shows when you see, decent responses in anatomy, but not great responses in vision. And so I think even controlled trials like Protocol U, which were plagued a little bit by that, make it hard to interpret, the real world results.
Yeah, I totally agree with you. I think that these are certainly inherent limitations with RVO and DME studies, which we have to acknowledge whenever we kind of consider this and its conclusion. So thank you for that. Okay, great. So we're going to go into a break and another sponsor presentation. And then we have our upcoming geographic atrophy session, non-neovascular AMD studies that we're going to be focusing on for that. First, I'd like to thank Apellis again for their silver sponsor presentation, and I believe they're going to be doing a presentation now. Thank you again for your support.
Hello, I'm excited to share with you information regarding Syfovre, pegcetacoplan injection. Syfovre was the first FDA-approved treatment for geographic atrophy, secondary to age-related macular degeneration. Syfovre is contraindicated in patients with ocular or periocular infections and in patients with active intraocular inflammation. Of approved GA treatments, Syfovre had the longest continuously enrolled GA programs, as well as the largest enrollment and most injections, with more than 1,200 patients and approximately 15,000 injections in clinical trials. Syfovre has been used in real-world practice since March of 2023, with over 78,000 vials distributed since launch. These trials were designed to enroll a population reflective of patients with GA who may be seen in real-world clinical practice, including patients with and without subfoveal involvement in the study eye at baseline, and patients with or without a history of or active CNV in the fellow eye. Patients enrolled in Oaks and Derby had to meet the GA lesion requirements, be 60 years of age or older, and have a BCVA reading of at least 24 letters in the study eye. Patients were excluded if their GA diagnosis was secondary to a condition other than AMD, if they had a history of or active CNV in the study eye, and if they had previously participated in any other interventional clinical trial for GA. Patients with either GA, CNV, or both in the fellow eye were permitted in Syfovre trials. 1,258 patients were enrolled across both phase 3 Syfovre clinical trials, OAKS and DERBY. Both trials were double masked and randomized 2 to 2 to 1 to 1. Dosing arms consisted of Syfovre every other month or monthly, and sham every other month or monthly. Of note, Syfovre is the only approved GA treatment to include every other month dosing from the start of clinical trials. The trial assessment was the change from baseline in rate of GA lesion area growth measured by FAF. Both trials were completed at 24 months. Patients who completed OAKS or DERBY were eligible to continue into the ongoing 3-year open label extension study, which is referred to as the GALE trial. In the OAKS trial, Syfovre achieved continuous reductions in lesion growth rate through month 24. At month 24, Syfovre demonstrated an 18% reduction in lesion growth rate versus sham pooled with every other month dosing, and a 22% reduction in lesion growth rate versus sham pooled with monthly dosing. In the DERBY trial, Syfovre achieved continuous reductions in lesion growth through month 24. And at month 24, Syfovre demonstrated a 17% reduction in lesion growth rate versus sham pooled with every other month dosing, and an 18% reduction in lesion growth rate versus sham pooled in the monthly dosing arm. In a combined analysis of OAKS and DERBY, Syfovre reduced lesion growth rate through month 24. Syfovre monthly and every other month reduced GA lesion growth rate versus sham pooled at each 6-month interval, slowing GA progression with increasing effects over time. Percent reductions versus sham pooled between month 0 and month 24 were estimated from a piecewise linear slope model with 6-month segments. The combined piecewise linear analysis did not have a pre-specified statistical procedure controlling for type 1 error. Syfovre has an established safety profile. This was established in 2 phase 3 trials with over 1,200 patients, 839 of which received Syfovre in OAKS and DERBY. Adverse reactions combined in OAKS and DERBY reported in at least 2% of patients treated with Syfovre were as follows: ocular discomfort, neovascular AMD, vitreous floaters, conjunctival hemorrhage, vitreous detachment, retinal hemorrhage, punctate keratitis, posterior capsule opacification, interocular inflammation, and increased interocular pressure. Endophthalmitis, retinal detachment, hyphema, and retinal tears were reported in less than 1% of patients. Optic ischemic neuropathy was reported in 1.7% of patients treated monthly, 0.2% of patients treated every other month, and 0% of patients assigned to sham. Deaths were reported in 6.7% of patients treated monthly, 3.6% of patients treated every other month, and 3.8% of patients assigned to sham. The rates and causes of death were consistent with the elderly study population. In conclusion, for patients with GA, choose Syfovre. Safety and efficacy profile is established in a population reflective of GA patients who may be seen in real-world clinical practice. And Syfovre slowed GA progression in both monthly and every other month dosing.
Indication: Syfovre pegcetacoplan injection is indicated for the treatment of geographic atrophy, GA, secondary to age-related macular degeneration, AMD. Important safety information. Contraindications. Syfovre is contraindicated in patients with ocular or periocular infections and in patients with active intraocular inflammation. Warnings and precautions. endophthalmitis and retinal detachments. Intravitreal injections, including those with Syfovre, may be associated with endophthalmitis and retinal detachments. Proper aseptic injection technique must always be used when administering Syfovre to minimize the risk of endophthalmitis. Patients should be instructed to report any symptoms suggestive of endophthalmitis or retinal detachment without delay and should be managed appropriately. Neovascular AMD. In clinical trials, use of Syfovre was associated with increased rates of neovascular wet AMD or choroidal neovascularization, 12% when administered monthly, 7% when administered every other month, and 3% in the control group by month 24. Patients receiving Syfovre should be monitored for signs of neovascular AMD. In case antivascular endothelial growth factor, anti-VEGF, is required, it should be given separately from Syfovre administration. Intraocular inflammation. In clinical trials, use of Syfovre was associated with episodes of intraocular inflammation, including vitritis, vitreal cells, iridocyclitis, uveitis, anterior chamber cells, iritis, and anterior chamber flare. After inflammation resolves, patients may resume treatment with Syfovre. Increased intraocular pressure. Acute increase in IOP may occur within minutes of any intravitreal injection, including with Syfovre. Perfusion of the optic nerve head should be monitored following the injection and managed as needed. Adverse reactions. Most common adverse reactions, incidence greater than or equal to 5%, are ocular discomfort, neovascular age-related macular degeneration, vitreous floaters, conjunctival hemorrhage.
Thank you for your attention. For additional information, please visit the Syfovre website at syfovreecp.com and visit our booth.
Great. I'm excited to take us into the next session on non-neovascular age-related macular degeneration and what real-world insights we have from that. I think this is a particularly hot area right now as we're finally in a world where there are some interventions to reduce the progression of geographic atrophy. So our first speaker will be Alexandra Rachitskaya from the Cole Eye Institute, Cleveland Clinic, and she'll be speaking to us on the assessment of geographic atrophy in an intermediate AMD population. Thank you.
Thank you, Durga, and it's such a pleasure to be with all of you today. And we'll be talking about GA in patients who are diagnosed with intermediate AMD. These are my financial disclosures. See, here we go. And of note, I consult both for Apellis and Iveric Bio, and I do research with Apellis. So when we think about geographic atrophy, the numbers show that worldwide, it affects about 5 million patients. And as the patients age, it affects them more frequently. 1 in 29 over age of 75 is reported to have geographic atrophy, and that increases to 1 in 4 as we go over age 90. That said, however, GA is not just one condition. We have GA developing from progression of intermediate AMD, which is the patients who usually have been included in clinical trials. But at the same time, we have patients who can develop geographic atrophy in an eye that's actively being treated for neovascular AMD, or GA in an eye with inactive macular neovascularization. And as Durga mentioned, we're now in the time where we have potential treatment options for our patients with geographic atrophy, including pegcetacoplan and avancicaptad pegol. So I believe that GA is probably underestimated, those numbers that I showed you. And there's some data to support that. This study by Senes et al. Showed that referring retina specialists in 24% of patients who had GA, they actually coded these patients as having intermediate AMD. Moreover, if we look at our patients who have exudative age-related macular degeneration and have evidence of GA on OCT, only 8% of those patients were coded as having geographic atrophy along with their neovascular AMD. Imaging becomes extremely important as we assess patients with GA. In particular, we're all familiar with fundus autofluorescence, but honestly, when I look at my clinic, I don't always get this fantastic fundus autofluorescence pictures, and sometimes it's actually hard to assess foveal involvement because fovea appears dark on FAF. And there's different patterns of fundus autofluorescence to guide us about possible progression. But OCT is our workhorse. It's the imaging modality that we all utilize in clinic every day. And there's definitions that are OCT-based to assess geographic atrophy. They include iRORA and cRORA, or incomplete RP and outer retinal atrophy, and complete RP and outer retinal atrophy. The difference basically is the size. iRORA is less than 250 microns, whereas cRORA is more than 250 microns. And when we look, the CAM criteria, the definition is hypertransmission into the choroid, as shown here in red, zone of attenuation or disruption of RP, as shown here with the blue arrow, and overlying photoreceptor degeneration that includes the thinning of the outer nuclear layer, disruption of ELM, and disintegrity of ellipsoid zone, as well as this subsidence of the outer plexiform layer and inner nuclear layer that's shown as in red as that diving in, and also the presence of the hyperreflective wedge-shaped bands. And as I mentioned, when we think about cRORA, that is the region of hypertransmission that is more than 250 microns. And although these are classic definitions, sometimes in a busy clinic, it's hard to spend time to identify all these findings. So the question is, what about utilizing our OCT the way we do it in clinic and see if that can be helpful to us to identify GA lesions? So this is how I usually look at geographic atrophy using SD-OCT. In particular, I utilize sub-RP illumination analysis as shown in this picture. That outlines the areas of geographic atrophy. And there's been a lot of research done utilizing this analysis by Dr. Rosenfeld and other groups, showing that when you look at geographic atrophy, and especially if you adjust for segmentation errors, this is very close to fundus autofluorescence. So our group wanted to take a slightly different approach to this and look at patients who are diagnosed in the chart as intermediate age-related macular degeneration. So the ICD diagnosis is intermediate AMD, and see if we can use the OCT, in particular the sub-RP illumination analysis, to detect areas of geographic atrophy. So we had 690 eyes that were utilized using this method. As I mentioned, we followed the same methodology that's been previously published. And this is how it looked. So we were able to determine the area and also the shortest distance from the lesion to the center of the fovea. And what we found that out of 690 eyes, OCT identified atrophy in 129 of them. When we went and looked at those areas, we confirmed that in 79 of these eyes, there was atrophy. We wanted to, though, be very particular and look only at iRORA and cRORA, and we determined that 49 eyes, or 7.1%, had iRORA and cRORA. And this is the distribution of these lesions by size. They mostly were small and in close distance to the fovea, and some of them included the foveal center. And we can see that these patients who had GA lesions and were diagnosed as intermediate AMD, the 41 patients, they were older, and the 49 eyes had worse visual acuity. So in conclusion, we saw that we had out of 690 eyes that we retrospectively analyzed, the OCT identified atrophy in 18.7%, but when we looked strictly at iRORA and cRORA, it was about 7.1%. And some of those patients exhibited foveal involvement, and they were older and had worse visual acuity. We also looked at the systemic comorbidities to see if there was any association, and in this cohort, we didn't see any association. So as we think about Let's see if I can advance. As we think about geographic atrophy, it's probably under-recognized, and multimodal imaging is extremely important. And now our study in particular shows that if you use OCT analysis as an adjunctive tool, it might help us increase GA detection. And I really want to give a shout out and big thank you to the two people who led this project at Cola Institute. Andre Sigiata was our fellow and currently practices in Montreal. And Chris Matuk was a medical student at the time and currently is the PGY1 ophthalmology resident in Chicago. And thank you for your attention.
Wonderful. Thank you so much, Alexandra. Next, we have Dan Gong from Massachusetts Eye and Ear Infirmary, and he'll be speaking to us about conversion rates of non-neovascular AMD to neovascular AMD. Thank you so much, Dan.
Thank you for the introduction, Durga, and thank you for the opportunity to present. I have no relevant financial disclosures. And so I just realized that I'm sneaking in a non-GA talk for this last session. But so our group has been interested in looking at conversion rates from non-exudative to exudative AMD across really different AMD patient populations. But this talk in particular is going to focus on one subset of our work, which is looking at patients who already have unilateral exudative AMD in one eye, and we're looking at their conversion rates in their fellow eye. And so from previous studies, we have learned that from post-hoc analyses of randomized controlled trials, we previously have found that within about a 2-year period, there's anywhere between a 23, 24 to 38% conversion rate for these fellow eyes. And in some more recent work that was a prospective study with a smaller number, about 95 patients or so, there's about a 6% conversion rate at 6 months. And so for our study, we utilized the IRIS registry, and without going into details, obviously it's several magnitudes of order larger in terms of the number of patients that we are able to include. And so for this study, we looked at a 4-year time frame from 2016 to 2019, and included about 87,000 patients that were diagnosed with having unilateral exudative AMD using ICD-10 diagnosis codes. We looked at several different patient characteristics. Ones that are of interest that I'll highlight later include smoking status. We also looked at their AMD stage, both based on the eye that already has the unilateral exudative AMD and also the stage of disease in their fellow eye that is still currently non-exudative at the beginning of the study. We also looked at the anti-VEGF treatment medication that was given initially for the fellow eye once they converted. And we created a Cox proportional hazard model to describe our analyses. So for our IRIS studies at Mass Eye and Ear, one thing that we've been doing in terms of presenting patient demographics is actually comparing it with, so we take our study population and compare it with the IRIS registry population as a whole. And when we look at the unilateral exudative AMD cohort, there are a couple of things that come about, not surprising, but there are a high percentage of women, high percentage of Caucasians, and also more active and former smokers in our study population. This next slide basically summarizes our main findings, and so I'll spend a little bit of time here. So this is highlighting, or this is basically a visual analysis of the hazard ratios across the different characteristics that we're looking at. So among the initial patient population of 87,000 patients, there were about 10.7% of patients who had converted during the study period. When comparing female patients with unilateral exudative AMD, male patients converted at a lower rate with a hazard ratio of 0.84. And then when compared with Caucasian patients, Asian patients and Black patients converted at a lower rate with a hazard ratio of 0.6 and 0.64 respectively. When compared with never smokers, active smokers had a higher rate of conversion with a hazard ratio of 1.12. Of note, the former smoker group had a hazard ratio of 1.06, although that was not statistically significant. And then probably not surprisingly, the more advanced stage the dry or the non-exudative AMD eye was, the higher rates of conversion. So compared to patients who had early non-exudative AMD in the fellow eye, those with intermediate stages had a higher hazard ratio of 1.35, and with advanced hazard ratio of 1.49. And then if we looked at the eye that had already converted and compared patients with active CNV in that eye with exudative AMD, patients who had inactive CNV and inactive scars had a lower rate of conversion. So I think clinically probably fits with what we expect. We also looked at anti-VEGF treatment. This is kind of the initial treatment that was given for the fellow eye once it converted. Bevacizumab and aflibercept were given a little more commonly than ranibizumab. And then if we looked at the race, smoking status, and region breakdown, for the most part, things were pretty similar, although Caucasians and patients actually in the North Central region, to what we call the Midwest region, was basically had higher rates of getting aflibercept as the initial medication. And so with this study, what we found is that females, Caucasians, and active smokers had higher rates of conversion in their fellow eye. And then patients with more advanced stages of non-exudative AMD in the fellow eye and with active choroidal neovascularization in their already converted eye had higher rates of conversion as well. We also talked about some racial and regional differences. For our study, we actually didn't have information about insurance. This is just based on the IRIS registry data set that we had initially for this study. And so probably some of this might explain some of these racial and regional differences. I'd like to thank my collaborators for their help with the study.
Great. Thank you so much, Dan. Next, we have Asan Rahimi from Palo Alto Medical Foundation and the Byers Eye Institute at Stanford, and he'll be speaking to us about retrospective real-world analysis of patients with geographic atrophy secondary to age-related macular degeneration followed for 3 years. Thanks, Asan.
Thanks, Durga. Nice to see you. Good morning. I'd like to thank the organizing committee for the opportunity to present today, and I'd also like to thank my co-authors for their collaborative efforts on this project. These are my relevant disclosures for this talk. So longer-term outcomes regarding the progression of geographic atrophy in patients with macular degeneration are generally lacking. Herein, the objective of this study was to report data from a retrospective analysis of the AAO's IRIS registry, evaluating disease progression of patients with GA in one eye and either GA or CNV in the other eye over a 3-year period. So the same group had previously presented and published on the 2-year outcomes. When looking at the methodologies, we started with over 125,000 patients after applying the appropriate ICD diagnosis code for GA in at least one eye between the listed dates. After applying appropriate exclusionary criteria, we were down to a little over 78,000 patients. Then, once excluding patients with under 3 years of follow-up, the final number included for analysis had dropped by over half to 36,817 patients, highlighting the susceptibility of this patient population to being lost to follow-up, due in large part to the lack of available treatment options previously. Eyes were then classified into 2 cohorts. Cohort 1 in blue represented patients with bilateral GA, totaling 21,789 patients, while cohort 2 in orange represented patients with CNV in their fellow eye, totaling 14,976 patients. Each group was then further subdivided into the location of the GA lesions as either extrafoveal or foveal, denoted by 1A, 1B, 2A, 2B. As you can see here, patient demographics were fairly balanced between both cohorts, with the exception of the treating provider. As we can see here, and would seem intuitive, patients with CNV in the fellow eye were far more likely to be cared for by a retina specialist, whereas there was more of a mix, including other ophthalmologists and optometrists in the bilateral GA group, potentially lending some insight into where many of these patients may be in the eye care provider sphere. When looking at study eye progression through year 3, progression to foveal involving GA was more common amongst bilateral GA patients than those with CNV in the fellow eye, with 17.6% of patients showing progression by year 3 compared to 12.4%. That's on the top left-hand graph that you see there. On the right-hand side, we evaluated for progression from extrafoveal and foveal GA to new onset CNV in the study eye. And not surprisingly, conversion to CNV in the study eye was more common in eyes with CNV in the fellow eye already. Over 30% of these eyes developed CNV by year 3, compared to under 15% of eyes in the bilateral GA cohort. Also, you can see that progression to choroidal neovascularization was slightly higher amongst eyes with extrafoveal versus foveal GA. When we looked at median time to progression of extrafoveal to foveal GA, was roughly 98 weeks in the newly incident groups and between 71 to 79 weeks in the prevalent groups, which, if you compare to some historical data from like AREDS, this is much faster than previously recorded. Interestingly, when evaluating median time to progression of new onset choroidal neovascularization, you can see that the time to progression appeared faster amongst patients with CNV already in their fellow eye compared to bilateral GA eyes. When looking at baseline vision, this was slightly worse amongst cohort 2 eyes at about 56 ETDRS letters compared to cohort 1 with 64.8 letters. Overall, though, visual acuity was relatively preserved at baseline, with over half of patients having 20/40 or better vision in both cohorts. And then as we looked at progression rates and the risk for severe vision loss, by year 3, nearly 1/3 of study eyes in both cohorts had deteriorated to vision of worse than 20/200 in each cohort that were not previously in that group at baseline. And bear in mind with the methodologies, these were the patients better seeing eyes. So this is meeting the criteria for legal blindness at this point. This final slide, this is a little busy, but what it's essentially showing is the vision change map over 1, 2, and 3 years, denoted by the different color bars. As one would expect, there's a progressive, consistent loss of vision across all 4 subcohorts. Generally speaking, patients with better starting vision tend to lose more vision during the study period compared to those with poor starting vision, suggestive of a floor effect. So in conclusion, we know geographic atrophy caused substantial disease burden in this retrospective study of a large real-world database. This is the largest reported to date. Eyes with GA lost significant vision over a 3-year period, consistent with trends in the previously reported and published 2-year analyses. Eyes with good vision at baseline lost more letters over 3 years compared to eyes with poor vision. And patients with GA are still at significant risk of being lost to follow-up, as evidenced by more than 42,000 patients being excluded from this analysis with less than 3 years of follow-up data. Thank you again for the opportunity to present.
Thanks so much, Hassan. Next, we'll have Ted Lang from the Byers Eye Institute at Stanford speaking to us about characterizing real-world functional outcomes in patients with geographic atrophy, an iris registry analysis. Thanks for joining us.
Thank you so much, Durga, and the other organizers for allowing me to present here on behalf of my co-authors, you can see here. Trying to advance. Okay, here we go. So I have served on an advisory board for Apellis, who also funded this study. Geographic atrophy accounts for 20% of eyes with severe vision loss and macular degeneration. However, real-world data and correlations between GA progression and functional decline are lacking. So to address this gap, we performed a retrospective cohort analysis of patient notes to assess the feasibility of quantifying vision-related quality of life and patient-reported outcomes in geographic atrophy. Specific emphasis was placed on the social, functional, and mobility-related outcomes to determine whether these measures can be used to assess the quality of life impact of geographic atrophy. Our study consisted of 2 parts. First, we analyzed clinic notes of GA patients to determine relevant keywords that were associated with quality of life endpoints. Then we compared the results for those who were newly diagnosed with GA in cohort 1 versus those that had been living with GA for at least 3 years in cohort 2. We took a random sample of 100 notes from each cohort and then looked at the prevalence of specific keywords and then looked at the context in which those words were used. You can see some of the more common keywords that came up during our analysis, grouped by functional, social, mobility, and then other categories. We search across all the clinic notes in any text field, and then we use these keywords as possible endpoints of interest. Looking at the demographics for our study, you can see that cohort 2 was slightly older because they had been living with GA for at least 3 years and had more subfocal disease than cohort 1. So here are the most common keywords that were identified. You can see by looking at these percentages that physicians in general didn't use keywords very often in their notes. The most common keyword was only used in 15% of encounters. Moreover, when we analyzed whether the keyword that appeared was contextually relevant to GA, we saw a wide range, all the way from 0 to 100% relevance, and correlation. What this told us was that retina specialist documentation of functional outcomes is limited, and that low vision specialists may be playing a larger role in the management of vision loss. Also, documentation of functional outcomes in the EHR was sparse, with more emphasis on disease progression over patient function. Now, the most common keywords mentioned were driving and reading ability, as well as referrals to low vision specialists. So in the second part of this analysis, we took the keywords identified in part 1 and randomly sampled 50 visit notes to review the clinical context. Again, we looked at driving, reading, and low vision concepts. For driving, the terms night driving and trouble driving were properly contextualized 30 to 34% of the time. Difficulty reading was properly contextualized 44% of the time, and referral to a low vision specialist was properly contextualized 74% of the time. What we learned from the second part was that it can be difficult to determine if the impacts on functional vision are due to other comorbid conditions like cataracts or other retinal disease, as these were not controlled for. Despite these limitations, understanding the holistic health burden among patients with GA is valuable, and future studies should focus on patients with substantial vision acuity decline, those managed by low vision specialists, and those with asymmetric GA and pseudophakic patients. So, in conclusion, vision-related outcomes are infrequently documented in the EHR, limiting the utility of these records for assessing functional outcomes. Retina specialists often refer patients with GA to low vision specialists who may be more likely to monitor and document changes in functional outcomes. While clinical notes are one source of these analyses, variable documentation patterns indicate that additional data sources may be needed. While regulatory agencies have advocated for the use of patient-centered outcomes in clinical trials, real-world assessment of patient outcomes is lacking, necessitating improved tools to collect this real-world data. Thank you so much.
Wonderful. Thank you, Ted. If there's any questions in the chat, feel free to add them, but I'll get started with our panel discussion. Ted, earlier in the session this morning, someone brought up a great question about what is the best way to capture functional outcomes for patients, I think particularly GA patients. What you showed in your study is that currently we're not doing a great job of it. Any thoughts on that, how we can get better real-world functional outcome data?
Well, I think, if you know you're being watched and potentially having your data analyzed later on, you're going to be more mindful about and more methodic and intentional about what you're putting into the EHR. But without that sort of prompt for physicians, I think, as a community, now that we have treatments for GA, I think we'll hopefully start using more specific tests that will assess the functional outcomes of patients, like low luminance visual acuity, low contrast, reading speed, and other measures that will hopefully filter its way into these types of analyses in the future.
Great points. This is a question for everyone, and I can call on people or y'all can contribute as you have thoughts on this. But I think one of the things that's particularly relevant right now is now that we have treatments, how do we best monitor any safety signals we might see in the real world? What are the best data sources to use? Should we rely on physician reporting to the FDA, services like the REST committee, claims data, EHR data? Asan, I'll start with you. What are your thoughts on that?
I think it's probably a combination of all of these. Obviously, physician reporting events is what got everything started with the REST committee in the first place, back with brolucizumab, and that just started with a couple of doctors on their chat groups noticing that there was events happening there. So that's obviously a very important source. We have the REST committee and their updates. The FDA's adverse event reporting system is also equally important. We have access now to multiple large data sets. We're involved in some database studies using one platform called Trinetics. There's also an insurance claim. So I think it's a collective effort. It's no one source is going to be perfect.
Great. Alexandra, thoughts on that?
So I totally agree with what's been said. I think it's though very important for physicians to report, if you have cases that you're concerned about, and also to try to get additional imaging, because I think a lot of times when we hear about the cases, it's very hard to tell what the patient looked like because the imaging is incomplete. And so I think all of us are very well aware, if you see a patient that you're concerned to get, for instance, fluorescein angiography, to get fundus photography, because I think we'll all will learn more if we have more data about those patients. But it is a very complicated, situation, I think, and we're all learning together as, within our community of retina specialists. And I applaud of all the work that's being done by everybody to try to keep our patients as safe as possible.
Great. I think now that we have some treatments available to at least slow the progression of geographic atrophy, the types of patients that we may be seeing both coded through structured data and then even just showing up in EHR registries may be different. Hassan, I noticed in your study using the IRIS registry, it's tough to follow patients for 3 years and hard to know why there's some attrition, whether the patients are passing away or because, maybe they're going to optometrists, because for the longest time, we didn't really have anything that we could do for them. And I know you showed a difference between the patients that have neovascular AMD in one eye and who don't. Do you think there's utility in trying to do some of these kind of longitudinal studies again in maybe a year or two once we have more patients in the retina clinic with GA?
Yeah, absolutely. I feel like we talked about this at ASRS one time too, and you had given your analysis, and then we said this will be very interesting to report repeat 1 to 2 years after the fact, now that treatment is out there, and see how everything shifts and the trends change over time. I think this would be a great study to repeat again in about probably the next 1 to 2 years and see how this shifts and see are we seeing an increase in patients, and are we seeing more patients getting funneled into the retina specialist? Because I think everybody here would agree, the diagnosis of GA is severely underdiagnosed relative to what kind of gets reported out there. And then B, we know a lot of those patients, they're either in the optometrist office out in the community, or a lot of them just don't come back in. They go see one eye care provider once, told there's no treatment, they never come back in, and we lose them from the system. Certainly, to your point, some of them do end up, passing away, and some of those are from deaths. But I think the vast majority of these patients are being lost to follow-up, and that is likely, hopefully, subject to change, and we can hopefully recuperate these patients back into the system now that we have treatments.
And I think that's a great point. And I think ties in also, Dan, to your study where you talked about conversion of non-neovascular AMD to neovascular AMD. I mean, really all we have is the data once the patient starts seeing the ophthalmologist. Do you think, if we did your study and we'd have more sort of pre-index data on these neovascular AMD patients?
Yeah, I think that's one of the things that we were struggling with, which is, are we really capturing, patients with newly diagnosed, whatever it is, that we're trying to study. I think in part of the reason why we've been presenting this specific work more than some of the others is that I think it's a little bit easier to define this patient population, where we know that their fellow eye is converting for the first time because we have been following the other eye already, and so they're probably well established. But I think, along with GA and other conditions, sometimes they're newly diagnosed according to the HR, according to the IRIS register, whatever it may be. But is that truly the case? And I think, just piggybacking actually off of the GA conversations, I feel like in clinical practice now, my conversations have changed a little bit, where I'm telling patients, come back in 6 months, because there are new therapeutics that are out, and obviously we're studying efficacy and we're studying safety. And I don't have a definitive answer for you today, but maybe in 3 months or 6 months I will. And I think it is worth another return trip. And so hopefully that will motivate more patients to return to us as retina doctors, even if for this moment we're not offering anything for one reason or another.
Yeah, Derek, I'd throw back in with GA, more than I think anything else we deal with in retina, is the concept of survivorship bias, because so many patients get lost to follow-up that I'd argue a lot of our findings, like even in the analysis I presented, are probably not what's real if you actually were to capture all the data that's out there. So again, to repeat these studies in the future, and hopefully we're getting more retention, I wouldn't be surprised if a lot of the findings we see are radically different.
I agree. I think there's a lot of work to be done in this area, which is exciting. Well, thank you so much to all of our panelists for this session. I think we'll just conclude with a few just remarks after a great morning. Just want to thank you all for attending. I think we've had great participation from the audience, great participation from the faculty that have been speaking. And I think first, I want to thank all of our sponsors, really, Genentech, Regeneron, Apellis, and Iveric Bio for making this possible. And thank you to all of our speakers and to my course co-directors, Brian Vanderbeek and Rishi Singh. This started as just an idea amongst the three of us at a retina meeting last year. So it's really great to see this come to fruition. I think over the course of the morning, we've had the opportunity to understand different data sources, to look at sophisticated methods to really leverage those data sources and understand what the current data insights are that we have in some key areas in retina: geographic atrophy, retinal vascular disease, and neovascular AMD. So we really look forward to your feedback and continued discussion about how we can really maintain this robust forum for advancing real-world data insights in ophthalmology. We encourage all of you to provide input via the survey. We'll send that to you shortly. And thank you so much. Hope you all enjoy the rest of your weekend.
Thank you, Durga.